Response and outcome of neoadjuvant chemoradiation in locally advanced carcinoma rectum, a single institutional observational study. Introduction. Locally advanced rectal cancer is challenging due to the risk of local recurrence and distant metastasis. Neoadjuvant chemoradiation is a standard treatment modality aimed at tumor downstaging, improving surgical outcome in locally advanced carcinoma rectum. This study evaluates the tumor response, pathological complete response, and side effect of neoadjuvant chemoradiation in locally advanced rectal cancer patient. Aims and objectives: to assess the response following adjuvant chemoradiation in locally advanced carcinoma rectum and to identify its toxicity profile. Methodology: study design. It's a single institutional observational study. The sample size was 30. Study setting: Department of Radiation Oncology from Sri Mohambiye Institute of Medical Science, and duration of study was 14 months from April 2023 to June 2024. Study subject under Radiation Oncology Department. Study participants: inclusion criteria: age above 18 years and below 75 years, ECOG performance status of 0 to 2, biopsy proven adenocarcinoma, all T3, T4 and T1, T2 with no positivity. Exclusion criteria: any systemic disease contraindicated for administration of chemotherapy, any contraindication for chemoradiation or surgery, and ECOG performance status of 3 to 4 and metastatic disease. So, age between 30 to 45% is around 6.7%, and age between 46 to 60 is around 63.3%, and age between 60 to 75 was 30%, and the male gender distribution is more, which was 53.3%, and female was 46.7%. Distribution of patient with respect to T stage and the nodal stage. Distribution of patient with respect to tumor location. The proximal rectum, it was around 16.7%, and mid rectum and lower rectum was 63.3%, and lower rectum extending to anal canal was around 20%. With informed consent, history and clinical examination was done. Pre-treatment evaluation, routine blood investigations, MRI pelvis with abdomen, and CT screening was done. CT simulation was done with the bowel and bladder protocol, and the planning treatment was done with 3D CRT or IMRT technique. Treatment protocol: patient who received a 3D CRT technique have received 45 gray in 25 fraction followed by tumor boost to 50 gray, and patient who received IMRT technique have received 45 gray in 25 fraction followed by simultaneous integrated boost to 50 gray in 25 fraction, and all patients have received concurrent chemotherapy capecitabine 825 mg per meter square twice daily, only on RT days. Toxicity profile: patient who received 3D CRT had a grade 1 and 2 toxicity of 10 patients, and bowel toxicity grade 1 and 2 for 13 patients, and grade 1 and 2 neutropenia, total of 9 patients, and grade 3 and 4 for 2 patients, and who received IMRT had a grade 1 and 2 toxicity of 5 patients, and 9 patients had a grade 1 and 2 bowel toxicity, and total 3 patients had a neutropenia of grade 1 and 2. Tumor response was assessed via MRA based tumor regression score grade 6 to 8 weeks post treatment followed by radical surgery. And for radiological response, 13.3% had a grade 1 tumor regression grade, and 16.7 patient had a grade 2 tumor regression grade, and 33.3% had a tumor regression grade, and 23.3 patient had a grade 4 toxicity grade. So all patient underwent radical surgery, and the pathological response was evaluated using the modified Ryan tumor regression score. Post-operatively, all patients have received adjuvant chemotherapy with the Capox regimen 6 weekly, Q21 days, and 13.3 patient had a complete pathological response, and 13.3 patient had a stable disease, and 73.3 patient had a partial response. Follow-up: after completing treatment, patient was followed up every 3 months with clinical examination and serum CEA. CECT abdomen and pelvis and CT screening was done every 6 months post-treatment. And on follow-up, total 4 patients had developed a recurrence. 2 patients had a pelvic lymph node mets, and 2 patients had a lung and liver mets. Discussion: in this study, concurrent preoperative chemoradiation significantly improves the pathological complete response rate and tumor downstaging while maintaining the safety and tolerability. IMRT demonstrated reduced toxicity compared to 3D CRT, highlighting its potential as a preferred treatment modality for the patient population. It emphasized the effectiveness of neoadjuvant chemoradiation in managing the locally advanced rectal cancer and underscores the importance of minimizing the treatment-related toxicity for better patient outcome. These are my references. Thank you.
So one comment and then one question. So whenever you present any of your work, what are the sequences which you follow? One is title, then your background, then aims and objectives, then methodology, and then result, and then discussion or conclusion final, right? So what I observed that methodology and your results were mixing, right? You did not define the methodology under the heading methodology, right? Because sometimes you are telling the result, then again how did you plan radiotherapy, that is part of methodology, then again what was the response, then again all underwent surgery, that is again part of methodology. So all these methodology should have come under methodology category, and then you show us the results in terms of demographic and what are the complete response. So that part is missing, that part was not up to the mark. Second, you said that neutropenia was less in IMRT. So did you practice that bone marrow sparing or no bone marrow sparing? Because if it is a simple IMRT, I don't think that it will have any effect. Neutropenia will be primarily because of chemotherapy, which was common in both the groups. So that was my second question.
What was the dose of capecitabine which you followed?
Sir, on patient who receiving chemo radiation, we give 825 milligram per meter square twice daily.
825. So this was given on the days of radiation or on all days?
Only on radiation days, sir.
So how many, what was the timing? What was the timing?
1 hour before radiation on empty stomach, sir.
And how many complete responses?
13.3%, sir, had a pathological complete response.
All patients, did they undergo surgery?
Yeah, sir. In my study, I took a patient who underwent surgery, sir.
And are there patients who did not turn up for surgery?
That was not, in my study, I was not included that patient, sir.
Your study, is it consecutive cases of rectal cancer seen in your institution? Or you have taken it randomly?
Randomly, sir.
Thank you. We'll move on to the next presentation. The next presentation is by Dr. Reshma. The second presentation by Dr. Reshma.
Good morning all, I'm Dr. Good morning all, I'm Dr. Reshma Raghunath and my presentation today is on curative intent robotic radiosurgery for medically inoperable and residual renal mass from Amrita Institute of Medical Sciences. Radical or partial nephrectomy is the standard of care for patients with primary renal cell carcinoma. But now we have emerging data in support of SBRT as a novel, non-invasive nephron-sparing alternative for patients who are medically inoperable, technically high risk, or who decline surgery. The study was to look at the oncological outcomes in terms of clinical and radiological response and renal function changes treated with SBRT at our center. Between 2000 24, 17 RCC patients were treated at our center after multidisciplinary tumor board and accrual, baseline imaging with MRI or CT scan, and baseline creatinine and GFR CT SIM scan and single gold fiducial placement under local anesthesia. Contouring and planning was done, and a dose between 25 to 45 gray in 5 fractions were delivered with fiducial tracking on CyberKnife M6 machine. Assessment was done at every 6 monthly follow-up with imaging with CT or MRI and with creatinine and GFR. This was done using IBM SPSS version 21. Moving on to results, mean age at presentation was 66.9 years and 70% of our patients were males. 15 out of 17 patients had multiple comorbidities, medically inoperable patients. 1 patient had solitary kidney and 1 was a case of stage 4 CKD. 9 out of 17 patients had a coexisting CLD. They were incidentally detected and 5 were diagnosed during evaluation of non-specific complaints like loss of weight and had a left-sided renal mass, and the most common location was upper pole in 8, followed by interpolar region in 5 and lower pole in 4 patients. Most commonly observed histology was clear cell carcinoma in 23.5, followed by papillary carcinoma in 12% of our patients. Moving on to dosimetry, median prescription dose was 35 gray in 5 fractions with an interquartile range between 35 to 40. 2 patients received a lower dose of 25 and 30 gray in view of solitary kidney and CKD. We were able to a median max dose of 40 gray within the PTV with an IQR between 40 to 44 grays. Median treated volume was 44.3% of the PTV was covered with a median dose of 34.8 gray and median prescription isodose was 90%. 33% of contralateral kidney received a median dose of 4.04 gray and 60% kidney received a median dose of 3.39 gray. 17.5 gray was received by ipsilateral median kidney volume of 0.03 cc bowel received a median dose of 34.9 gray. Months with an IQR between 4.5 to 17.5 months, 14 patients were alive, 2 expired from decompensated CLE, that is non-disease, non-treatment related complication, and 1 patient was lost. 1 patient had pre-existing macros of hematuria persisting, and 1 patient developed CHF. Radiological response, none had radiological progression at median follow-up of 11 months. At 6 months with 14 evaluable patients, 2 showed interval reduction in size with 12 stable disease. At 1 year with 8 evaluable patients, 2 showed interval reduction with 6 stable disease. This is the pre and post-treatment MRI images showing an interval reduction. Coming to toxicity profile, post-fiducial complications of hematuria, perirenal hematoma, and fiducial migration were seen in 1 patient each, which were self-limiting. With conservative management, we were able to take up the patients for radiation within 1 week. Fiducial migration treatment, patient had a refiducial placed after 1 week. None of the patients had acute grade 2 or more of GAGU toxicities. First image is showing a perirenal hematoma and second one is showing a fiducial migration seen in the check scan 2 days post-fiducial to anterior abdomen wall. Moving to GFR parameters, our baseline GFR was 69 ml per minute. At post-study 6 months, the median GFR was 81.5 ml per minute, and at post-study 1 year, median GFR was 87 ml per minute. This is the graph showing GFR change over time for all of our 17 patients. As we can see, most patients are showing a stable trend, with 3 showing a decline and 4 showing mild improvement. For patients at the range of 40 ml per minute, both patients are showing mild improvement in GFR parameters from baseline. At 6 months, we have observed a median GFR improvement of 4 ml per minute and a median GFR decline of 7 ml per minute. At 1 year, we have observed a median GFR improvement of 7 ml per minute, median GFR decline of 15 ml per minute. To conclude, at median of 35 gray in 5 fractions and median follow-up of 11 months with IQR between 4.5 to 17.5, none of 14 patients, 2 had radiological response and 12 stable disease. At 1 year with 8 evaluable, 2 had radiological response and 6 stable disease. Fiducial related complications were seen in 3 patients, 2 or more acute GIGU toxicities. 64 and 37% patients had GFR improvement of 4 and 7 ml per minute at 6 months and 1 year. 36% and 63% patients had median GFR 6 months and 1 year. Thus, out of the 15 evaluable patients at 6 months follow-up, 14 treated with SBRT showed good local control with no major renal function toxicity, and 1 patient was lost to follow-up. The local control rates was comparable to the existing. Thank you.
At a time when there are very good systemic therapies available, what was the pressing treatment for your
So the mainstay of treatment in RCC is main local treatment modality is surgery, and when the patient is not a surgically fit, medically fit patient for undergoing surgery, radiation is a good alternative compared to the previously used cryoablative measures with renal preserving.
But you could not achieve a complete response in any of the cases, isn't it?
So
what was your follow-up treatment?
So none of the patients received any distant metastasis or any local recurrence. Most of the patients under follow-up had a stable disease. 2 were showing interval reduction, and most of these patients has a lower follow-up period, sir. That is one limitation of my study, that 1 patient was lost to follow-up, and out of 17 patients, 1 losing is more than 10% of the loss to follow-up. That is one limitation, sir. And second is the follow-up duration is lesser. But none of the patients developed any mets.
Can you elaborate on the subsequent treatment which these patients had?
None of the patients
that has a bearing on the outcome.
Okay, sir. So none of the patients had to undergo any further treatment regarding renal cell carcinoma. They are being kept under follow-up, sir. With a few more years of follow-up, maybe we'll be able to elaborate more on that, sir. But for now, none of the patients had to receive any further treatment for renal cell carcinoma. And another thing noticed was that most of these patients had multiple comorbidities and decompensated CLD, and 2 patients expired from the same, sir.
And you said 1 patient had renal problems and 1 patient had only 1 kidney.
Yes, sir.
But still you proceeded.
So
Is there any reason why you preferred treating them with a cyber knife rather than your tomotherapy or conventional INAC?
So we have a cyberknife machine at our center. So with fiducial tracking, we were able to better deliver the dose in a conformal way.
So there is no doubt that the role is upcoming in SBRT role in renal cell carcinoma, especially who are medically inoperable. So that's fine. So my question is that the variation in doses, from 30 to 45 gray, right? If you look at EQD2, there will be a huge variation. So what was the criteria of deciding 30 gray and the 45 gray? Because the number of fractions were same, 5 fractions. So why
Yes.
there was so much of variation in the doses?
So, most of the dose decision was based on the patient characteristic. 2 patients received a lower dose in view of salt thickening and CKD.
I'm not asking about those 2 patients.
Regarding the location of the tumors, in upper pole lesions, we were able to give a much higher dose. And all of the dosing was taken from previously existing literature, sir.
All right. So mainly because you were not able to achieve the
dose
proper
constraints,
constraint to
yes,
the
sir.
surrounding normal tissue. So that was the only criteria, right?
Yes, sir.
So, but that again is going to affect your outcome when your BED will be different, in different patient. Second is that histopathology, majority of them were unknown. What do you mean by unknown histopathology?
For them, pre-treatment histopathology was not
Biopsy was not done.
sir.
So based on radiological imaging and PET scan, you diagnose and decide to treat.
Yes, sir. Most patients were referred from urology in view of surgical unfitness. Thank you.
Next presenter, Dr. Sevika Nagarajan, presenting on adenocarcinoma of cervix treated with chemoradiotherapy, a retrospective study. Dr. Sevika.
A very good morning all. I'm Dr. Sevika N from Amrita Institute of Medical Science, Kochi. I'll be presenting my study on adenocarcinoma of cervix treated with chemoradiation therapy, a retrospective study. So carcinoma cervix ranks 4th among women worldwide and 2nd in India. So carcinoma cervix is majorly a squamous cell type and only 21 to 25% accounts for adenocarcinoma. So human papillomavirus causes 92% of cervical carcinoma cases and almost all squamous cells and 80% of adenocarcinoma are positive for HPV. Adenocarcinoma is a very heterogeneous disease, including a different histological subtypes. According to International Endocervical Adenocarcinoma Criteria and Classification, it's broadly divided into HPV-associated and HPV-independent. And HPV-associated is further divided into usual type adenocarcinoma that is composed of micropapillary and below glandular, and the other is the mucinous adenocarcinoma cell and smile type of mucinous adenocarcinomas. The gastric type clear cell adenocarcinoma and mesonephric adenocarcinoma is categorized under the HPV independent type. So human papilloma virus infection in HPV associated cancer, we can use PCR. So objective of our study is to assess the response among the main histological subtypes of adenocarcinoma cases of cervix treated with the definitive chemoradiation therapy at our institute. It's a single institute retrospective observational study conducted between January 2016 to August 20. 8 cases of carcinoma cervix, and we kept our inclusion criteria like we included only the adenocarcinoma histology and a patient who received definitive chemoradiation therapy followed by the brachytherapy. And we excluded the patients with a stage 4 disease and patient who received adjuvant chemoradiation types other than the adenocarcinoma. By following our inclusion and exclusion criteria, out of 238 cervical carcinomas, we filtered out 12 associated and HPV independent adenocarcinomas. Moving to the results, our demography details consist of 23 adenocarcinoma patients, age group of 61 years and interquadrantile range of 56 to 69 years. 17 patients were P16 positive and 6 patients were P16 negative. And the majority of these patients have stage 2B disease and 6 of them had the stage 3.1C1 disease. Of adenocarcinoma receive EBRT to a dose of 45 to 50 gray in 25 fractions for 5 fractions per week over a period of 5 weeks, and 5 cases were treated with 3D-CRT technique and 18 cases were treated with IMRT technique. Followed by EBRT, all the 22 patients received image-guided high-dose brachytherapy of 7 gray in 3 to 4 fractions. All these 22 patients received 5 cycles of concurrent chemoradiation therapy with cisplatin in 19 cases and carboplatin in 4 cases. So non-compliance to the 5 cycles of chemotherapy was seen in one patient due to the severe neutropenia, and one patient had a non-compliance to brachytherapy since she developed a pneumonia episode, and further 2 cycles of brachytherapy, 2 fractions of brachytherapy was avoided. RT-induced acute toxicities were seen, grade 1 toxicities were seen in 6 patients, and grade 2 toxicity was seen in 2 patients, and none of the patients had grade 3 or 4 toxicities. So of 23 patients, 2 patients lost follow-up after the CTRT, and of 21 patients, imaging at 3rd month post-CTRT showed complete response in 20 patients, and 1 patient showed a residual disease. And the patient with residual disease is a P16 negative patient of stage 2B disease, and she was treated with the salvage chemotherapy. On median follow-up with 20 months in patients with complete response, 4 progressed, and patients with local recurrence and nodal metastasis had treated with salvage chemotherapy with paclitaxel and carboplatin, and they had a progression-free interval of around I've been treated with a PFS of had a PSF of 41 months. I've been treated with palliative radiation therapy and palliative chemotherapy. One patient had a local recurrence, nodal recurrence, and PFS of 15 months, and she was treated with salvage chemotherapy followed by the maintenance bevacizumab. So on comparing the recurrence in adenocarcinoma subtypes, out of 17 cases of P16 positive, 1 patient had recurrence, and of 6 patients with P16 negative, 3 patients is higher in the P16 negative cases when compared to the P16 positive cases. So at a last follow-up, 19 patients were alive, and 1 patient had the grade 2 radiation-induced rectal proctitis. To the squamous cell carcinomas. So more effective treatment to improve the prognosis of adenocarcinomas were desired. A retrospective study conducted by Araki et al. In Japan with adenocarcinoma patients demonstrated that using the cisplatin and paclitaxel CCRT achieves considerably good local control, regional failure or the recurrence. So from our institutional experience on patients treated with CTRT for adenocarcinoma cervix, a higher failure rate than HPV positive patients. So HPV negative adenocarcinoma of cervix may warrant treatment escalation in HPV positive patients. So these are my reference. Thank you.
So you said carboplatin concurrent
Yes, sir.
is producing better results as per your review of literature. But have you switched over to paclitaxel carboplatin concurrently with that, the radiation?
Concurrent, is there a try?
Are you now giving?
No, sir. We are as of now we are practicing the cisplatin only single agent concurrent chemotherapy regimen at our institute, sir.
You haven't switched over to carboplatin paclitaxel, isn't it?
Concurrently, with radiation we have not. So single agent concurrent chemo radiation therapy we are following as of now.
How did you
Sir.
choose between cisplatin and carboplatin?
Sir, it depends upon the patient's peers and renal clearance and comorbidities, sir. If patient is having a renal impairment, we choose the carboplatin more than the cisplatin. And if any complications, neutropenia or rising creatinine, then we can switch over to the carboplatin regimen, sir.
So you mean to say that carboplatin is safer than cisplatin in renal impairment when the patient is having?
Yes, sir, most likely. Efficacy-wise, both cisplatin and carboplatin are equal efficacy, but carboplatin is more safer in the renal patients with renal impairment group.
How many of these patients subsequently underwent surgery?
None of our patients underwent surgery, sir. So the 4 patients have progressed, but all of them have put on a salvage chemotherapy and maintenance. One patient with the distance and local recurrence put on a salvage chemotherapy and maintenance bevacizumab, sir. Post chemotherapy, the patients had responses, so they were kept on maintenance and follow-up, sir.
But as a policy, in your gynecology
Guidelines.
postdoctoral training center, do they take up these patients for primary surgery?
Sir, up to 1B1, 1B2, we take up for surgery or RT, sir. The option is like a single mode, either we go for surgery or RT, but most preferentially up to B1, 1B2, we go up for the surgery, sir. And mostly from 1B3 cases, we go for the concurrent chemotherapy, sir. Chemoradiation therapy.
So what Dr. Madhu is saying that, when you have a local recurrence, the first option is salvage surgery. But in your presentation, I think none of the patient was offered salvage surgery, even when patient having just local recurrences. So that is something surprising.
Sir, because the patients who had a local residence or a 2B cases, so the involvement of parametrium was there. So we basically thought of giving...
pelvic exentation is
yes,
the
sir.
answer.
So we thought...
so that provide you the best chance of local control. Anyway, this P16 estimation, is it part of your routine workup?
Yes, sir.
For every carcinoma cervix patient, right from 2016 onwards, you are doing it
yes,
routinely?
Sir. We are routinely performing the IHC markers of P16 and CEA also we are performing.
You're performing.
Performing in our institutes. Thank you, sir.
Thank you, Dr. Sevika. With this, we come to an end of the oral presentations. Now we will have a 5-minute break.
the breast MDT. I invite Dr. Krishnaji, Professor Pathology, Sri Gogula Medical College and Research Foundation, Dr. Priya V, Professor, Radiation Oncology, Government Medical College, Kottayam, Dr. Nisha Devi, Clinical Oncologist, Salmania Medical Complex, Bahrain, Dr. Gobika P, Consultant, Medical Oncology, Aster MIMS Hospital, Kannur. I invite the respected dignitaries to come to the stage and occupy their seats. And I also invite Dr. Aravindis Anand, Professor and HOD, Radiation Oncology, Government Medical College, Trivandrum, to moderate the session.
First case. Oh, right, yeah. Thank you. Good morning, all of you. So, this is a breast MDT. We usually come across a lot of common cases in the breast discussion. So this MDT is purely rare case scenarios are being presented here. So we don't have much data on these cases. So we have to depend mainly on the single institution studies or case series. And we need some MDT discussions to decide upon the treatment. I'm not talking about all the cases, but some of the cases are like that. Okay, shall we start? So with me is Dr. Gopika and Krishna Madam and Dr. Priya and Dr. Nisha. Shall we start? Okay. So the first case is a 58-year-old lady who is asymptomatic. She had a screening bilateral mammogram that shows left breast upper outer quadrant clustered macrocalcification with no definite mass. The right breast is within normal limits. Vacuum-assisted biopsy with clip insertion done. And the histopathology shows intermediate grade DCIs, ductal carcinoma in situ with no invasive cancer, and the IHC is awaited. To Dr. Nisha, how will you proceed?
Thank you for the question. So regarding this case, you have diagnosed as a DCIS, right? Yeah, DCIS. So first we'll have a thorough clinical examination,
yeah.
And we can suggest bilateral MRI in this case to make sure that there is no, in the same breast, there is no hidden malignancy, and also to see any contralateral presence of malignancy in the invasive cancer in the opposite breast. And our aim here is to prevent the transformation to an invasive cancer, because we see that around 12% of cases, they transform to invasive cancer. And regarding the surgical management, we would suggest BCS followed by radiation,
yeah.
depending upon the histopathology. And if at all you are going for a mastectomy, would like to plan for a sentinel lymph node biopsy, because post-mastectomy, if you detect an invasive cancer, then it will be difficult for an SLNB here. And we have seen in many cases, they say that there is a chance of invasive cancer after the pathology report, around 10 to 20% of cases are found to have invasive cancer components.
Okay, so you will either proceed with a breast conservation surgery with a sentinel lymph node, breast conservation surgery, or a mastectomy with an SLNB.
Yeah.
So what are the other situations you recommend sentinel lymph node biopsy? Because ductal carcinoma in situ, we don't expect much of axillary lymph node positivity. Is there any other condition where you would suggest SLNB?
Okay, and basically, as I said, suppose you're going for a mastectomy, as we already explained, or if you have a large area of microcalcification, you have to consider. And also, if you have a palpable lump in the breast, we do consider for sentinel lymph node biopsy.
Yeah. So this patient actually opted for a breast conservation surgery, and she had the tumor removed, and the specimen is sent for the reporting. Krishna Madam, routinely how we report a ductal carcinoma in situ specimen?
Now, DCA is reporting the main headings by which we have to go is you have to locate the tumor site in the specimen, the clock position, the histologic type, size, that is extent of the lesion in the sections, the architectural pattern, the nuclear grade, presence or absence of necrosis, microcalcification, and the margins. Are they free or involved? Then distance from each margin and the closest margin. Then if there are regional lymph nodes sent for pathology, the number of lymph nodes, the size of metastatic deposit, the largest size of the mets, extra isolated tumor cells. So there are definite guidelines by CAP protocol by which you can decide the size and isolated tumor cells.
Okay.
Next slide. It's there.
Thank you, madam. This is how you report a case of DCIS, no? Okay, thank you, madam. And shall I move to Dr. Priya now? She has completed her breast conservation surgery, and the histopathology was initially DCIS. Now, this patient has an intermediate grade DCIS, and all the margins were clear. And do you recommend any radiation treatment for her?
Yes, it is an intermediate grade DCS.
Yeah, it's intermediate grade.
Grade DCS. Yeah. And you mentioned that the margin is close. It's not 2 millimeters.
Yeah.
It is 1 millimeter.
Yeah, one of the margins is
one
just
of the margin is 1 millimeter.
Yeah.
So definitely I'll advise an adjunct radiation. That is, since the patient has undergone BCS also.
Yeah.
So because that is found that it can reduce the local recurrence by about 50% of the ipsilateral breast cancer recurrence.
Okay.
And also in the early breast cancer trialist group analysis, meta-analysis, it was found that it is able to reduce the local recurrence. The 5 years it was 10% absolute gain was there.
Yeah.
And in 10 years it was 15%. So definitely I'll go for whole breast irradiation.
So the indication for radiation treatment for this particular patient is the intermediate risk.
Along with
one of the margin was
positive.
Okay.
Now this was supported by other trials also.
Yeah.
Like NSA-BP 17, then Swedish DCIS, then UK NZ trials. All this supported that local recurrence can be reduced significantly with
though that is not translated into the overall survival. Okay, good. So, is there any subset of patient in ductal carcinoma in situ you could avoid radiation treatment safely?
Yeah.
Is there any subset?
Yes, there is a subset where there is low-grade DCS in postmenopausal where the size of the lesion is less than 2.5 centimeter. The margins are adequate, ER negative, all those, and HER2 also negative. I mean, ER positive, HER2 negative.
Yeah.
In that subset of patients, we can safely avoid radiation.
Yeah. So you want to have all the conditions satisfied. So you want it should be a low-grade tumor.
Without
all the margins more than 2 millimeters in size. Okay, right. So what is your radiation treatment volumes and what dose you prescribe?
For whole breast radiation, in our institution, we go for a moderate hyperfractionated regime with 40 gray 15 fractions. And in this case, since it's a close margin, chances of local recurrence will be it will be higher because from the studies it has shown that is from the pathological evidence and also from the clinical observation, most of the local failures occurs around the site of primary location of the tumor. So definitely I'll go for a boost of the tumor bed also. So for that I go, in our institution we give 10 gray 5 fractions.
This is an intermediate risk DCIS, not an invasive cancer. You still want to go for a boost or you still prefer to have, you want to go for a boost? Or
and definitely I'll go for, because the margin is close. It's only 1 millimeter.
Okay, right. So regarding the boost, actually for an in situ, there is a bit of controversy there.
No, if adequate margins was there,
you would have.
I would have avoided.
Okay, right. So, will you go for 26 in 5?
That's, according to the fast forward trial,
Yeah.
the inclusion criteria, DCS was not included.
You know.
It was fully 41 to T3 and
Yeah.
0 disease.
Yeah.
For DCS, definitely we can go for a, if there is 26 grade 5 fraction, whole breast irradiation.
Yeah, you can go with 26 and 5 as well. Though we don't have a trial that shows.
It's an extrapolation of.
It's just an extrapolation of the.
What we have done as in
1450. Actually, in the, I think the Start B trial also, that was the same thing. They extrapolated the result that was there for the invasive cancers to the DCI. So now the standard of care is hypofractionation. Safely you can give in DCIs as well, either 14, 15 or 26 and 5. Okay, thank you so much. And Dr. Gopika, is there any role for hormones in this patient?
Sir, this is hormone positive disease, no?
Yeah, it's a hormone positive.
Okay, for hormone positive disease, we give adjuvant tamoxifen 20 milligram OD for 5 years, and it has shown that it reduces ipsilateral and contralateral breast events. It is based on a meta-analysis of 2 trials, NSABP B24 and UKNSZ trials. It has shown that it reduces both ipsilateral and contralateral breast cancer events, and the hazard ratio is 0.75. So we can start tamoxifen, and it is, we know that tamoxifen has some side effects like venous thromboembolism, pulmonary embolism, endometrial cancers. So we should discuss with the patient about the benefit. The benefit is not as much as in invasive carcinoma, so we should discuss before starting the risk versus benefit ratio, and we should start. And in some patients, if we think there are risk of tamoxifen, there's a data for low dose tamoxifen, that is tamoxifen 5 milligram OD for 3 years based on a trial, TAM-01 trial. So it has shown that reduces 50% chance of reduction recurrences, but it was not compared with the standard dose, it was compared with placebo. So it has shown, since this is a premenopausal lady, we go for tamoxifen. If it is postmenopausal, there is data with anastrozole also. Okay. We can give anastrozole.
Right. So you want to give hormones if the patient doesn't have much risk factors like thromboembolisms or like the chance for any
endometrial cancers
or hyperplasia or cancers. You prefer to give.
Yes, for
you will
5
discuss
years.
with the patient.
Yes, benefit and the risk.
Not like the invasive cancer where routinely advised. Oh, that's great. So, and even low dose.
Low dose tamoxifen, 5 milligram for 3 years.
Good. So, what is the follow-up plan? The patient has now completed the treatment. So, in a DCIS, what is your follow-up plan?
Actually, we do a clinical examination every 6 months for 5 years, and also the annual mammogram for 5 years we routinely do.
Okay. So what's the take-home message from the first cases? The DCIs can be treated either by a breast conservation surgery or a mastectomy with an SLNB. We should aim for at least 2 mm clearance. There is a subset of patient whom we could avoid adjuvant RT. All others need RT. And the subset is basically a screen-detected, post-menopausal, low-grade, tumor less than 2.5. There is, again, a controversy in that. Some prefer for 1.5 centimeter. And the margin clearance of more than 2 millimeters. You can go with the 2 hypofractionation schedule. And tamoxifen is advised case by case, the merit basis. And Dr. Gobia mentioned we can even think of postmenopausal anastrozole. That is also again extrapolation, or is
we have trial. We have
trials as well. So in that case, you are not thinking of any the chance for endometrial hypoplasia. You are thinking of some other toxicity of the patient, like aromatase inhibitor. You want to discuss with the patient.
Yes, we'll
you are the osteopenia and all those things.
All those osteoporosis.
Right. Okay. So shall we move on to the next case? That's case 2. So this is again another case which we routinely come in our clinical practice, but we are a bit confused. So 45-year-old premenopausal lady, para-2 live 2, present with right breast lump of 3 months, clinical examination showing 2 centimeter hard lump in the upper outer quadrant of the right breast with axilla, no nodes. Two-cut biopsy shows again DCI is high grade, and she underwent a wide local excision. And the histopathology shows ductal carcinoma, high grade, tumor 2 centimeter. Tumor 2 centimeter means the whole of the ductal, DCS component, and with a foci of microinvasion. All the margins were more than 2 millimeters. A foci of microinvasion. Now this is sent to our Krishna madam for the expert opinion. Madam, can you just comment on this slide?
You have a pointer?
This one? Ah, yeah. Yeah, that's okay.
Filled with the tumor cells, and these are the areas of necrosis. So DCIS with the necrosis is considered as high grade, and the nuclei, if you check in high power, it will be showing highest level of aneplasia. Now here you can see a cluster of a foci where the small cells are going in, groups of cells are invading. This you have to measure in the you can measure using microscopic micrometer we call it, and the invasive foci less than 1 millimeter. So when the invasive foci beyond the basement membrane of these ductal structures is less than 1 millimeter, you are getting the presence and absence of myoepithelial cells. As you can see, these are the IHC staining markers. There are several markers for demonstrating the myoepithelial and the basement membrane. Now this is the myoepithelial cell which forms the outer layer of the luminal ductal epithelial cell. So if they are intact, the basement membrane is intact and there is nothing. So that is what is highlighted here also. But if you stain these ducts, demonstrate that there is a breach in the basement membrane and the cells are going into the stroma. So that is microinvasion. And you can see a single focus or multiple focus, but the criteria 2020 WHO actually mention whether the number of foci is important. But they do mention if one foci is in continuity with the next focus, you should not call it microinvasive. You have to call it cancer. So that much of careful evaluation of histopathology section is required. Multiple sections you have to follow the standard rule, 1 section per centimeter of the tumor.
Okay, thank you, madam. So,
what I said, a lesion which is characterized by one or more separate foci of infiltrating tumor cells into the mammary stroma, each less or equal to 1 millimeter. Now this microinvasive cancer is usually associated with high-grade DCIS. So IHC, several markers are available, alpha SMA, caldesmon, CD10, CK14 is supposed to be very good for breast, and so also P63.
okay. Thank you, madam. So now, Dr. Nisha, this is a case of now right upper quadrant high-grade DCS of size 2 centimeter with a foci of microinvasion, ER positive, HER2 also positive. Okay, what is the role of sentinel node biopsy in this patient? Do you recommend for our particular patient? And in general, what are your thoughts on sentinel lymph node biopsy in microinvasion?
Regarding sentinel lymph node biopsy, in the case of microinvasion, the consensus is a little unclear because the involvement of lymph nodes in the case of microinvasive cancer is like less than around 5%. But still, because we have seen that is mostly associated with high-grade DCIS and HER2 positivity, in case it turns invasive, it will be highly aggressive. So that's a school of thought to go ahead with SLNB, though you see in the long term, there is no outcome differences, basically.
So you have to take a decision, no? In our particular case, is there any factor that guides you? Because we have to sit in the MDT, we have to make a decision. So this is our MDT.
We would
so this is a
advise-
high-grade DCIS.
In this particular case, I would advise actually, because it's a high-grade DCIS.
So what the take-home message is that we have to sit in the MDT, discuss each case.
Yes, of course.
In a case of
by-
micro-invasion,
yeah,
case
it
by
sh-
case.
Yeah, it should be a customized decision
Yeah.
by case. And
Yeah.
in this case, because of HER2 positivity
Exactly,
and
yeah.
high-grade
Exactly.
DCIS,
So-
would recommend.
So you go with a sentinel lymph node biopsy as well for this patient. So is there any difference between the surgical margins? You know, like in DCIS, we mentioned that we need a 2 mm margin, and invasive cancers, we know that there should not be any tumor cells on the margin, either in situ or invasive. Should not be there in the margins. So your patient, and in general, what is your safe recommendation for that, regarding the margins?
Okay. Regarding the margins, because we have a case of microinvasive cancer, you have to see what is the DCIS component. So if the case is with an extensive, specifically with a DCIS component, then we go ahead with the same margins of DCIS, like 2 millimeter or more margins. But if it's a purely microinvasive case, then we go ahead with the same as an invasive cancer, like a clear inked margin like that.
So the villain here is again the DCIS. If there is a DCIS component, you are happy to
You
go
have
with
better wider margins, yeah, of course.
Yes.
Yes.
Otherwise, just a pure microinvasive
Yes, if
cancer,
you
you need only that is same as
Yeah.
that of the invasive
Yeah,
cancer.
that's
Thank you so much. And coming to Dr. Gopika, is there a role of any adjuvant systemic chemotherapy for this patient? And we already mentioned that it is a HER2 positive patient because madam has already reported as a HER2 positive case. So do you want any adjuvant treatment?
No, routinely there is no standard recommendation for giving adjuvant chemotherapy in microinvasive carcinoma, even if it is HER2 positive, because for HER2 positive we take 0.5 centimeter as the cutoff to give adjuvant chemo and anti-HER2 treatment. So, and in specific situations where some studies have shown that hormone negative microinvasive carcinomas do worse than hormone positive. So in that cases, like hormone negative node positivities or multiple foci of microinvasion, in those situations we consider we can consider adjuvant chemotherapy. But otherwise routine, even if HER2 positive a microinvasive carcinoma, we usually don't give adjuvant chemotherapy.
Yeah. Routinely you don't recommend any.
Routinely do not recommend.
But still again you sit and discuss about other factors and then you decide.
Any high risk factors like this hormone negative or like that negative cases we give.
Yeah, if it's a hormone positive, you'll go with the...
If hormone positive, we'll go with adjuvant endocrine therapy.
Yeah.
Recommendations as per DCIS, we give for 5 years.
Okay, fine. So now the patient is being referred to Dr. Priya. Do you want to give any radiation treatment to this patient?
This is a high-grade DCS with microinvasion.
Yeah.
So by the HPR itself, we know that it's an aggressive clinical and biological behavior.
Yeah.
So definitely we have to go for a adjuvant radiation.
Adjuvant radiation
Radiation.
Yeah.
Whole breast radiation, and I'll definitely go for a boost also.
You will go for a boost as well. Okay.
Because that is supported by my evidence from a big trial and a TROC trial, which shows that suppose if it is for a non-low grade DCS, low risk, not low grade, low risk DCS, there is evidence that suppose if we give hypofractionated RT along with tumor bed boost, and they have put 2 arms, one with tumor bed boost and the other without boost.
You're talking about the DCIS?
Yes, non-low grade DCS. That means high grade DCS and intermediate grade DCS. They found that in the case with boost, the local recurrence was 97%, and the other case without boost, it was 92%. And they have given an ultra hypofractionated regime also. Tested an ultra hypofractionated regime. But what happened was that when the boost was given, there was breast edema, breast induration, and breast pain. So they finally came to the conclusion that you better go with a moderated ultra hypofractionated with a tumor bed boost. to balance the local control, toxicity, and also the.
So you are worried about the cosmosis of the patient as well.
Yes, yes, definitely.
After the adjuvant RT. Then why can't you think of a partial breast irradiation for the patient?
This is a high
in this particular patient, do you think of a partial breast irradiation?
It does not fits into the criteria for partial breast radiation.
So if at all you think of a partial breast irradiation, what would be your criteria or as per the recommendation? This lady, I think what's the age of the patient was, I think less than 50.
45 years.
45 years, sorry. And
should be
yes,
more than 50 years.
what are the recommendation for that?
More than 50 years. Should be a low-grade DCS.
Then no, you're talking about the invasive cancers as well. Yeah. You know, this is a micro-invasive cancer.
Yeah.
No, in invasive cancers, I'm talking about the invasive cancers, will you go for a partial breast irradiation? So you talk about 50 years, then what are the other cutoff?
3 centimeter. So the lesion should be below 3 centimeter.
Okay,
it
fine.
should be node negative.
Node negative.
ER positive. HER2 negative. Only those patients.
So
and there should not be any extensive intraductal component.
Okay.
So for those patients, we can go for partial breast radiation.
Partial breast radiation. That's fine. Thank you. So shall we move on to the next case? That's case 3. This is a 40-year-old lady with right breast mass, 3 by 3 centimeter, no axillary lymph node. She has no prior imaging. The diagnostic mammogram and the targeted ultrasound of the breast reveal a lobulated mass with internal cleft. A core needle biopsy was performed. The biopsy result demonstrate a fibroepithelial lesion suspicious of malignant Phyllodes tumor. So we have very specifically mentioned suspicious of malignant Phyllodes tumor. Madam, with the core biopsy, Krishna madam, with the core biopsy, can we tell or confirm that it would be a case of malignant Phyllodes?
It is core biopsy showing a picture of fibroepithelial lesion. It is stroma proliferation and the epithelial component, ductal proliferation. A definite diagnosis with core biopsy for malignant Phyllodes is very, very limited, because Phyllodes tumor as such has got a very heterogeneous histology, and very close DD will be a cellular fibroadenoma and even some other mesenchymal lesions in the breast. So the core biopsy may not be representative of the actual histology in the whole tumor. So both FNA and true cut biopsy of the breast have got very limited role in diagnosing malignant Phyllodes. The factors the pathologists consider are the stromal cellularity, atypia, presence of mitosis, and judging stromal overgrowth. That is very important. It is actually the periductal stroma which is maximum proliferating in a Phyllodes tumor. So this judgment is very difficult in a true cut biopsy. So the malignant Phyllodes tumor with a highly suspicion is a clever wording by the pathologist, I would say, because the excision can turn out in benign Phyllodes or intermediate grade or some other mesenchymal malignancy. For stromal overgrowth judging, the criteria is you should see absence of a single duct in a low-power field. That criteria is difficult to employ in this minute piece of tissue. That is why the role of true cut in diagnosing Phyllodes is very, very limited. And on the excised specimen, as you see on the screen, we grade the Phyllodes according to 2012 WHO, the grading system: benign, borderline, and malignant, based on the criteria stromal cellularity, stromal atypia of the stromal cells, mitotic count, and the stromal overgrowth and tumor margins. So employing this, each of the 3 types, the benign will show a mild stromal cellularity, then stromal atypia will also be mild, and the mitotic figures will be less than 5-10 high-power field, and stromal overgrowth will be absent, and the margins will be well defined. But in borderline, the thing slightly changes. Cellularity will be increased when compared to the benign one. Atypia will also increase, and the mitotic count, look at it, ranges from 5 to 9 per 10 high-power field. then the overgrowth will be absent or very, very focal. The margins will again be well defined. But coming to the malignant phylloids, there will be marked increase in stromal cellularity, marked atypia, and the mitotic count will be more than 10 per 10 hyperfield. The necrosis will, stromal overgrowth will be present, and the margins will be infiltrative. That is why this criteria itself speak why the true cut biopsy has got a very limited role in diagnosing malignant phylloids tumor.
Okay, thank you, madam. So now the pathology is actually, it's a case of malignant phylloids from the core biopsy. Now what next steps in the management? Dr. Nisha.
We have confirmed malignant phylloids tumor.
Yeah.
A careful history and physical examination to make sure that there is no signs or symptoms of metastatic disease. So metastatic workup with a CT CAP is what I would recommend.
Yeah. So you want to take a proper history, and you will advise a CT thorax, abdomen and pelvis.
Yes.
Yeah, because it's a malignant.
Because it's malignant, there is instance of.
Okay. So if the CT tab shows no evidence of Mets, what will you advise?
So then it's a local disease, and
it's a small lesion.
Yeah, and we know that the surgery is the mainstay of treatment in the case of phylloids. So our aim is to achieve a wide resection with a good surgical margin of 1 centimeter or more. Basically, in the case of malignant phylloids, if it's suppose a benign phylloids, a clear margin would be sufficient. So here BCS with like an oncoplastic surgery reduction, or we can go for a mastectomy. In this case, after discussion, and considering the lymph node status, I mean, I don't think the SLNB is not recommended. No.
You won't advise the
surgeon? No, we will advise for a central lymph node.
Why in all other cases we are thinking of SLNB, but here we are not thinking of.
No, this is the pathology is totally different, and we don't. Yeah, we don't expect this to have a lymph node metastasis per se.
Yeah, if at all spread, it will be
systemic spread basically to maybe the lung or bone. It can.
Yeah, right. So what happened is this patient had undergone a lumpectomy, and the margin is less than 1 centimeter here. You aim 1 centimeter margin. You advise.
Yeah, one or more. Yeah.
Okay, and if it is less than 1 centimeter, and the surgeon tells that I can give you more margins, but sometimes that is going to affect the breast conservation. Sometimes that may go for a mastectomy. In that situation, do you want to advise them to go for mastectomy, or is there any data that we should be very stringent on the 1 centimeter concept?
Basically, in that case, if the whole outcome is going to be changed, we won't be that stringent regarding a re-excision. What we can go is we have to have a close surveillance, definitely, to make sure that there is no recurrence, because that's very common. I mean, the phylloids are well known for a local problem like that. But in this case, I would like to have the opinion of the radiation oncologist regarding an adjuvant treatment, whether it would be helpful for this case.
So you want to refer to your colleague who's sitting left to you,
yeah,
Dr.
of course.
Priya. So what is your thought? She is telling that there is a need for an adjuvant. Do you agree with her?
Yeah, I agree with because for borderline and malignant phylloids, the chance of recurrence, local recurrence, is the range of 18 to 21%.
Okay.
So we should consider whole breast radiation.
Okay.
And another thing is that suppose if the patient recurs for a borderline, it usually recurs as a malignant phenotype.
Yeah.
So malignant phylloids means it requires re-excision again.
Yeah.
So we can avoid an unnecessary surgery at least in 20 to 25% of the patients.
Yeah.
So definitely I'll go for a radiation.
So you'll go for radiation.
Yes.
So that means for all borderline and malignant phylloids. After lumpectomy, we would advise
because that is supported by evidence.
Evidence-based.
It's evidence-based.
Yeah.
A prospective study by Bath et al. Has shown that there is a 100% local control with radiation. There is only a 6.6 years follow-up and 56 months of follow-up was there, but there is a 100% local control was there. Right. And another study was conducted by Selvamani Madam from Chennai. And they also told that the outcome was, that is local control outcome was very good with
adjuvant RT. Yeah, I do agree. So, is the dose different from this?
No, it's same as
the carcinoma
only.
Yeah. Okay. Now, is there any role for systemic treatment for this patient? Dr. Gopika, is there any role? This is a malignant phylloids. Is there any role?
No, currently there are no standard recommendations for adjuvant chemotherapy. I think none of the international guidelines like MD Anderson, NCCN or French Sarcoma Society, they don't suggest or recommend adjuvant chemotherapy. And there was a prospective study from Mexico which compared adjuvant chemotherapy with doxorubicin and dacarbazine versus no chemo. There was no survival benefit with that also. So currently there is no guideline to suggest adjuvant chemotherapy. In some studies, a few studies, they say that like sarcomas we treat. So if the size is more than 10 centimeter, or if in case of breast, if there's chest wall involvement, considering it as a high risk, we can consider adjuvant chemotherapy, but it's not a standard. Some of them recommend to give.
Yeah, that's actually if the size is one of the criteria.
Like sarcoma, if we
but that is not a definite indication.
Not a definite indication.
Yeah, we need to discuss the pros and cons of the patient.
Yes.
And if at all you plan for a systemic chemotherapy, what will be your schedule? Is it sarcoma schedule?
Sarcoma schedule only. We go for sarcoma schedule.
Yeah. And you know that this is going to recur soon. Yeah. No? I think more than 18% chance.
18 to 20% chance of local recurrence.
So do you have a different surveillance pattern because we routinely go with annual
mammogram. In addition to that, we go with ultrasound of the breast every 6 months. In addition to clinical examination, we do USG breast to look for.
So that is an addition because that is
since local recurrence chance is high, we have to go for that.
So we don't have much recommendations, but still that some of these like the papers suggest that it's better to go with ultrasound 6 monthly in parallel with the annual mammogram that has been recommended. So as Madam already has discussed, the phylloids tumor is already rare and they can resemble fibroadenomas. So better to go with the lumpectomy specimen evaluation, then find out, because co-biopsy at times has its own demerits or deficiencies. So we aim for, in malignant phylloids, 1 centimeter margin, and in benign, if it is a focally positive, just leave it off and there is no need to go with a re-excision. And then adjuvant RT is recommended in borderline and malignant cases. So systemic therapy, the data is very, very limited, so we don't routinely recommend. So shall we go to the fourth case now? So we have, this is the fourth case. We have a 39-year-old lady. She is para-2 Ly2. She has no relevant family history of malignancy. She complains of right breast lump of 3 months duration. She complains of only right breast lump. But a mammogram was done that shows right breast 2 by 2 centimeter upper outer cotton mass with Birad's 5, but the mammogram picked up a left breast mass of 0.8 into 0.9 in the upper quadrant with Birad's 4. Bilateral axilla was within clinically and radiologically normal. The core biopsy was taken and a clip was inserted, that is because put a clip there from where exactly the biopsy was taken. And the histopathology shows in the right breast, IDs infiltrating ductal carcinoma, grade 2, ER 6 by 8, PR 6 by 8. That is the all-red score, HER2 negative, and KS67 10%. On the left side, it was again grade 2, but ER is only 0 by 8. And KS67 is 30%. So coming to Dr. Nisha, what next? It's a 39-year-old lady.
Okay, so we have a 39 young lady with a bilateral breast cancer over here. So basically, because it's a bilateral, we have to have a good history even regarding a family history in this case.
Yeah.
And then we go for like extensive workup for the metastasis, like we would have a CT scan and a bone scan or PET CT scan, because basically it's a young lady with a bilateral disease.
Yeah.
Plus, because this is an early disease and we want to go for, I would suggest MRI for the both breast. We want to see whether there's any multicentric disease because we can plan for BCS then if there is no multicentricity. So basically, these are the investigations I would like to suggest.
So you want to do a staging scan.
Staging, yeah.
So that is definitely needed. If it is needed, yeah.
Yeah, of course.
So if it had been one side alone, we should have been happy with just a chest X-ray and ultrasound.
Yep.
Unfortunately, this is a young lady who has a bilateral breast cancer.
Yeah.
So you want to go with the CT tab, or either you will go with the PET
CT, yeah,
PET
of course,
as well.
yes.
Okay. And but at the same time, you want to do an MRI of the.
Yeah, that is to see whether there is any multicentricity, so that we can plan for a surgery.
So that is done. It doesn't show any evidence of Mets now.
Okay.
How will you stage this patient? And what are thoughts on the molecular subtype?
Okay, again, come to this patient is having a bilateral disease.
Okay.
And we have in the right breast, we have like tumor-wise, it's an early disease, but you have HER2, ERPR is positive, hormone positive, HER2 negative, early breast, and this is in the right breast. Coming to the left breast, we have put it as like ER is like already 3/8, and you have a high KI 67. So with the HER2 negativity, this even though it is like 3/8, it's a very weakly positive ER. And in this case, being a young lady with a high KI 67, with a HER2 negativity, PR also negative, I would like to take this more like a basal cell, like a triple negative disease. Okay. So anyway, because it's hormone positive in the other breast, as per as the hormones, we take it as a hormone positive. We have to go ahead with hormones as well. Okay. But this would be this thing. So one side it will be like a hormone positive, and the other side, so different pathology. One will be the TNBC.
So the right side, it is a luminal A.
Luminal
side.
A, yeah.
And on the left side, already being 3/8, you are happy to take it as a case of triple negative. Yeah. Well, because we come quite often in our clinical practice, is 3/8. So when the already is 3/8, basically we are looking into the proportionate score, and that 2 might be give for, like if it is 1 to 9% positive, will give as 2. If it's less than 1% positive, we give as 1 actually. So here we would have given as 2, and it was weakly stained. So 2 plus 1, 3. So it's a weakly stained tumor cells are there, which is less than 10%. So in clinical practice and as per the NCCN as well, we have to take it as it responds similar to a hormone negative patient. So we need to think that it should be a triple negative breast cancer, and look at the KI60 is also the highest side as well. Okay, fine. So, and you have already advised this patient anything else, like any genetic studies? Or
yeah, of course. Because the patient is a young lady with a bilateral breast cancer. As I already told you, the history we have to take. Plus, we are talking about a TNBC here. So, added with all these things, definitely you should go for a BRCA testing, genetic counseling.
Yeah, if the patient agrees for the same.
Yeah, of course. We have to definitely, we have to discuss with the patient regarding all these things upfront.
So what is the treatment plan now for this patient now?
So after there is no metastasis, we have all those things. So after the workup here, this patient is having
non-metastatic.
Yeah, now basically even though it's bilateral disease, it's an early breast cancer bilaterally. So basically we can advise for a bilateral BCS with bilateral sentinel lymph node biopsy, followed by that regard, depending upon the HPR, the adjuvant treatment, and definitely patient will require adjuvant RT because we are going for BCS.
Okay. So the patient has now undergone bilateral breast conservation surgery with a sentinel lymph node biopsy, and the specimen was sent to Madam. And Madam, can you just report on this?
Now the right breast is showing an IDC grade 2, PT1C, SLLB is 1 lymph node positive, 6/8 ER, PR is 6/8, HER2 is 1 plus and DCIS is plus. Present left breast as again grade 2 IDC, T1B, SLNB 1 micromets. ER is low there, 3 by 8, PR 0, HER2 negative, and again DCIS is present. Now, the diagnosis of bilateral breast cancer, there is a challenging question to be answered by the pathologist, and that is to decide whether the second one is a primary or it's a METS. It's a very challenging question, and traditionally we used to be teaching students, and the textbooks taught us that presence of DCIS component in the second tumor confirms that it could be the primary. But now, these days, the literature is challenging because secondary deposits from the breast, earlier diagnosed as cancer, those cells can home the ductal epithelium inside. So this takes us to further studies and further tests to confirm that whether the second breast is actually a primary or it is a secondary. So bilateral breast cancer, the diagnosis of primary rests in deciding the clonality of the population of the second cancer cells. So there are clonality studies which are done on the cell cultures on the chromosomes to decide the clone of the cells and say whether they are the primary, second primary, or a metastatic deposit. It's not easy, and it's not done routinely. Now it is there in research to decide the clonality of the tumor cells in the second breast, to decide that both are bilateral primaries.
So, madam, for our routine decision making to tell that it is a synchronous bilateral breast cancer, you mentioned that you look into the ductal carcinoma in situ component, and then you look into the estrogen, the molecular profile, then whether it's lobular or invasive, it's a similar morphology is there, and all these factors will be taken into account.
Yes.
But you definitely need a clonal assay.
Clonal assay.
But that is not routine. We are not doing that.
Not doing
so this case is again we have two different.
Here,
one is triple negative, and another is hormone positive.
That can happen because breast cancer is as a cancer which is very highly heterogeneous. Even the metastatic deposits, I have seen cases which were hormone positive in the primary, the METS deposits turns negative. It's very highly genetically heterogeneous clonal population of cells. The next clone in the metastatic deposit can lose hormones. We have seen cases.
So just for the audience, madam, I am asking one more thing. So it is arising from two different clones.
Yes.
So they are two different tumors.
You have to take it as two different tumors.
So, madam, in the report there was a mention of micrometastasis. Can you just tell what the micrometastasis is?
That we discussed micrometastasis in the lymph nodes. In the lymph node, the size, it is decided. See, any metastatic deposit measuring between 0.2 millimeters and less than 0.2 millimeters in diameter together. It is a micromets. Then isolated tumor cell clusters, you will see here and there in the lymph node, that should be less than 0.2 millimeters and less than 200 cells in a single cell cluster in a single cross section. So that much the pathologist has to count the number of cells. But because in the section of the lymph node, you will see multiple foci of the foreign population of cells. So those cells have to be counted and make sure that the isolated cells are less than 0.2 millimeters. If it comes to 0.2 millimeters, you call it as micromets in the lymph node.
Okay, thank you, madam. So now the patient surgery, and we confirmed that two primaries are there. Lymph node SLNB positive and the other is negative, and now the patient is with Dr. Gopika. So the patient is too much worried about the systemic chemotherapy as well. She's a very young lady. So what will you advise this patient?
Actually, if this would have been strong left breast, I would suggest oncotype DX, but this is, unfortunately, this is estrogen low positive, that is 3 by 8, high Ka 67. To go with chemotherapy, adjuvant chemotherapy, I would advise adjuvant chemotherapy rather than avoiding.
Yeah. So there is always a too early breast cancers.
Yes.
And you don't advise, and she is node positive.
Node positive, one sentinel lymph node positive. So Yes, we could advise oncotype DX, but
Yeah.
this is a premenopausal.
Just think that, that instead of the triple negative on the other side, and then you can think of doing your oncotype
Genomic
DX
studies like oncotype
separate tumors. No?
Yes.
You have two tumors now here.
Yes, we have to
So
do
we
separate.
can
Yes,
do separate, and
separate
then
studies.
we get the
Risk for each tumor, and then based.
and
Yes.
then you think of
giving systemic therapy.
But unfortunately, our patients not at
Not a candidate
because
for doing oncotype
low
DX.
estrogen receptor
Yes.
expressive.
For practical purpose, to take it as triple negative, better to take as triple negative.
Okay. So, what chemotherapy you plan for her?
Platinum based.
Or you want like adjuvant, or you just go with the AC and
AC and followed by taxane. So in
the adjuvant setting.
Adjuvant setting also.
Okay. So this lady consented for AC or EC into 4 followed by taxane, and she received 2. This is a practice. Sometimes we come across like the 2 cycles of the chemotherapy. We can see there is a mild derangement in the liver function test. Alkaline phosphatase is also normal, but the ALT is 90 and the AST is 100. So now we are just a bit worried. Will you continue with the AC chemotherapy in this particular patient?
Yes, actually for cyclophosphamide we can give the full dose. We can continue in full dose. Can give 75% of the dose. In these situations, I think it is between 2 to 3 times the upper limit of normal. So I think we can give 75% of the dose to chemotherapy based upon monitoring of the liver function test. We can give cyclophosphamide, we can give full dose.
So the take-home message from this is that you can continue with the cyclo as such.
As same dose, 100% dose.
But adriamycin, but the bilirubin is normal, you are happy with the enzymes gone 2 to 3 times only, 5%. If it would have been gone beyond 3 times.
Beyond 3 times, we give 50% dose reduction, and above that, more than 5.
Should anything we just think in our mind when we get some alteration in the liver function persistently? The first, in the second cycle it was there, in the third cycle it was there. Persistently, if the enzymes, the liver function enzymes are going. Any other things like you want to do any specific investigation and see whether everything is fine? Like you want to do something, think of any systemic meds or something for you can think. Waited.
We will wait and then.
Because you are expecting this.
Yes. Sometimes we see across.
But there is no harm in doing an ultrasound and seeing whether the patient is not. If it is a persistent elevation, like that's left to the consultant. Clinical thing. And now this patient is referred for adjuvant radiation treatment to. And I just want to know, in our routine practice, we ask the patient, when we see the patient, we tell that, oh, you need radiation treatment. You come on this day, finished off. And the patient is wondering what is going to happen with her. So please, how you consent this patient? What all things you will explain to her? And what is the rationale of it? Can you just brief on your technique as well?
She requires bilateral radiation. That I'll talk to her. Then cutting the right side of the right breast.
No, before going to that, at the time of consenting, you want to tell her that.
No, she's a young. In the long run. One thing that we can say. Then.
No, but with regard to the local radiation treatment, you explain to her about the techniques and everything. You consent the patient.
I'm coming to that.
Okay, thank you. Right.
There is a node positive, sentinel lymph node positivity.
So the right side,
But that was not addressed by surgery.
No, it was not addressed with an axillary node clearance. Just SLNB was positive. So she didn't go with the clearance.
So according to an Amaros trial, you can go for early breast cancer, you can go off with either radiation treatment or surgery. Either of the two.
She opted for, she's happy with the radiation.
Okay. And so in the right side, I'll go for a whole breast radiation. And since she is not positive, supraclavicular fossa radiation also.
Okay.
And on the left side, she is triple negative.
Yeah.
Triple negative, and along with that,
Negative.
but the proliferation index is also high.
Yeah.
So that side also requires, and it's post BCS.
Post BCS.
So definitely that side also requires
Definitely RT.
RT.
Yeah. The whole
breast radiation.
Yeah.
And in view of young age and high proliferation index,
Okay.
there is evidence that you have to go for a tumor bed boost also.
Give a boost as well.
The other side requires,
Yeah.
because it's not positivity.
Okay.
And
otherwise also she's, I think, less than
yeah,
50 years.
If
Yeah.
So,
So all the patients
all this,
above 50 you recommend for a
that is below 40 years of age.
yes, below 40. This is your cutoff is 40. Okay. Because I think in UK they put it as 50, I think. Okay, fine. Right. So you want to give a tumor. So what all in your consenting, what all things will be there?
She will be more worried about, I'll tell her that since there is a possibility of a lung and heart receiving radiation more than normal.
Yeah.
So I'll talk to her about the two techniques.
Yeah.
That is a this technique that is available in a high volume facilities and a limited resource setting.
Yeah.
And in the high volume setting, that is where all facilities are available, I'll ask afford.
Yeah.
Go for a VMAT with the DIBH.
So why you are thinking of giving a BMAT?
Ontos, then thinking of the OIS.
Okay.
That is heart and lung.
And and I think that the left tumor was on the inner quadrant as well.
Also.
And the scar was a bit towards the your RT wise, you are worried about something else. You want some overlap?
Yeah, overlap may be there, and it can produce. But in a limited resource setting, just like in ours, we have EMAT, but still we are giving bilateral breast radiation with 3D CRT only.
Yeah.
In that case, we go
Shall
for
we, before going to the 3D session, sorry for interrupting.
Okay.
Before going to 3D CRT, and what will be your dose and like you mentioned that you are planning of giving a. So you go in a DIBH technique, no?
Yeah.
Yeah. Okay. What dose you want to?
I'll read it with moderate hyperfractionated regime of 40 gray 15, followed by a boost of 10 gray 5 fractions.
Okay. And think of any SIB technique as well? Of any SIB, like can we go with some of
VMAT, we can do either a sequential boost or a
simultaneous integrated.
Simultaneous integrated boost. Suppose simultaneous integrated boost, I'll go for whole breast radiation. I'll give a dose of 40 gray 15, and for the boost cavity, I'll
in SIB.
Yeah.
Okay, right. Thank you. And you are talking about the 3D CRT as well. We could
because
think
we
of
have treated lots of patients with
the
3D
bilateral
CRT.
breast.
Yeah, bilateral.
Yeah.
In that case, what we do is we'll give a monoisocentric technique with a half beam block.
Yeah.
And by applying different weightage and also differential combination of beam energies, we'll see that whether we can switch off all the OAS, catch hold of all the OAS, as well as homogeneity of more than 7%. Okay. Then in addition to that, I'll explain to her the advantages of giving VMAT technique, because in that we'll be able to restrict the dose, that is the breast volume receiving more than 107%, will be 20%, and the mean lung dose and the mean heart dose can be reduced by 10%.
Yeah.
So I'll tell her all these advantages also for going for a modern RT technique.
Okay, thank you. So, and coming to Dr. Gopika, what is your endocrine treatment for this lady?
For a lady, so I should give tamoxifen Which is premenopausal, and if it becomes postmenopausal, you can switch over to aromatase inhibitor.
Yeah.
Then regarding OFS, I think this is early, very early disease. I think soft and text trials have shown more benefit in N2, N3 disease, less than 35 years, and grade 3 tumors. So this is very early, almost node negative or one sentinel lymph node positive. So better go with tamoxifen since she's premenopausal.
What about being a bilateral breast? Can we think of considering as a high risk, and then think of it's that can be that way also we can think about
yes,
that. No?
If we think there is a high risk feature, then we can add ovarian function.
So definitely you will be treating her with the tamoxifen. And regarding the ovarian suppression, we don't have much data whether in bilateral it should be taken as high risk, and then that should be given. Okay, thank you so much. And shall we move to the
Yes, sir. Dose-dense chemotherapy AC followed by taxanes.
And also if she is BRCA positive.
Yes, sir. Adjuvant olaparib if she is BRCA positive. Adjuvant olaparib also.
Thank you, sir. Thank you, Gopika. So,
in your earlier presentation, you had suggested ultra-hypofractionation. But would you like to give ultra-hypofractionation for both the breasts here?
this patient.
Yes.
So here actually we have an early breast actually. So we are treating the nodal area one side. If it is fear, that is in the right, I mentioned about the nodal positivity. Okay, the right side. So right we are incorporating the axilla. We don't go with 26 and 5. We go only with 14, 15.
Why, what is the problem?
Problem because
no,
the long-term
thing is,
yeah.
as an old-timer, I am anxious about the of radiation.
Dose per fraction
and,
on the highest side.
You are suddenly jumping into ultra-hypofractionated treatment, which may be good for our government medical colleges and things like that. But the thing is, all these things are to be done with a lot of caution and a very good planning.
Yeah.
And the target volume will have to be different. So, yesterday also somebody was presenting about the late effects when there is hypofractionation, ultra-hypofractionation.
Yeah, definitely.
So the thing is, ultimately, the side effects of radiotherapy will be coming into emerging in the years to come if ultra-hypofractionation.
Yes, sir. Sir, actually...
So this is my anxiety.
Yes, sir. You are very much true. The thing is, breast being like the alpha by beta being 3, so hypofractionation studies have come up. So we were following 15, 25, and then we changed 15 after definitely we have evidence. But with regard to the nodal, when you come with the nodal irradiation along with the breast, we didn't have much data in the START trials actually. Now recently, I think it's 1 month back or 2 months back, the hypo trial? The publication has come up, it means the data has come, where you can safely give 14, 15 in axilla, if you treat axilla also. Now, internationally accepted 14, 15 as a standard of care, even if there is a nodal irradiation. But 26 and 5, we don't advise for if there is a nodal irradiation. I'm coming back to Sir's genuine concern. Definitely we have to look into the OS, what the heart disease, what the lung disease. Do you have a DIBH technique available? All these should be noted, especially if you are treating with a left-sided breast cancer. So all that should be taken care of, rather than looking into the final results, and you should always look into the protocol, how these were done. So because we're running short, so this is This is another interesting case. I think this is a 43-year-old premenopausal lady, P2L2, presented with a left breast lump of 7 months duration. And on physical examination, there was a non-tender mass involving the whole breast, 1.5 centimeter on the centimeter, with a, it's a whole breast, non-tender mass involving the whole breast with a 2 into 1.5 centimeter left axillary node. The FN showed atypical lymphoid cells suggestive of malignancy. A core biopsy was taken and sent for this slide. So,
now the core biopsy from the suspected case of lymphoma will show just monotonous population of cells, blue cells in the background. So here the differential diagnosis, it is a lymphoma, or close differential diagnosis is a lobular carcinoma or a ductal carcinoma. So employing IHC is a must. So we have to do 2 markers, ideally completely a cytokeratin and LCA or CD45, just to bring out the nature of the tumor cells, whether they are epithelial or lymphoma cells. And you have to go ahead with other panel of markers for lymphoma to designate the type of lymphoma in the patient. So here in this slide you can see the monotonous population of round cells and a ductal structure here, and it is infiltrating the stroma diffusely. Now positivity for the LCA, which is leaving out the ductal epithelial structure as negative. Their areas are positive for lymphoma cells, and this is cytokeratin, which will highlight ductal epithelial cells. So that is, the ducts are positive, the tumor cells are negative. So that is how you judge a round cell neoplasm in a core biopsy of the from the breast tissue. So I think one more slide is there.
Madam, with the immunosa.
DLBCL markers?
No, the markers are just, just carry on, ma'am, please.
You can do further using the DL panel for lymphoma, whether to categorize it as a diffuse large B-cell lymphoma, which is the most common thing, followed by Burkitt's or a Malta-associated lymphoma. So for the panel, including CD20, CD79A, and the germinal center markers, and all those things you have to do to delineate the nature of the lymphoma, to so that will help you to.
So this is a diffuse large B-cell lymphoma.
Diffuse large B-cell germinal center type.
Okay, madam, is there any specific pathological criteria to tell that this is a primary breast lymphoma? Is there any pathological criteria? Yes, actually you have to be very sure that there is no disease elsewhere in the nodes. So this is the criteria which we employ, Weissman-Lea criteria. You have to have adequate specimen for diagnosis and tissues infiltrating in close proximity, no evidence of concurrent widespread disease except the synchronous ipsilateral axillary lymphadenopathy, and there should not be any diagnosis of extramammary lymphoma. That criteria, you can diagnose a primary lymphoma as a primary breast lymphoma, not a secondary thing which is coming from a nodal disease which was existing elsewhere. Okay, thank you, madam. So this is a case of primary breast lymphoma now. And Dr. Nisha, what all things you would advise?
So as we have already seen and discussed, this is a primary breast lymphoma, which is a quite rare event. So as madam has already explained what is the criteria to be followed, we have to go through a physical examination. We have to rule out any prior incidents of lymphoma in this patient, and also to see that the patient doesn't have any other evaluation by a PET CT scan suggested. And a lumbar puncture to see a CSF study also would be
Yeah, we can do a lumbar puncture and to see whether any.
Under the relevant blood investigations
Then
we
all
do
other
for the
bases. So
lymphoma. Lymphoma, it's a baseline study. She have a PET CT scan.
So she had a PET CT and that shows intense FDG FDT in the left breast and the left axilla. Dr. Gopika, so there is no other FDG avid lesion. So what could be the final diagnosis in this case?
A case of primary breast lymphoma.
Okay.
I think stage 2E. With, since axillary node is positive.
Yeah.
Then for management,
Yeah.
I would discuss this case in multidisciplinary and should also discuss with the patient about the prognosis, nature of the disease, and also would like to proceed with the chemoimmunotherapy, systemic therapy, ARCHOP 6 cycles, followed by consolidation radiotherapy. And regarding this high risk lymphoma, that's primary breast lymphoma, there is high chance of CNS metastasis. So I would like to give CNS prophylaxis with high dose methotrexate recommended in NCCN and also the British Society, in the British Journal of Hematology, they have advised to, it is a methotrexate 2 to 3 cycles after this ARCHOP chemotherapy.
So, yeah, this is a very high risk
case is managed.
Potential for
CNS metastasis.
So, I think the BSH journal that came 1 month back, I think. So, they definitely gives her intrathecal methotrexate. Unfortunately, there's a change.
For testicular, they advise to give intrathecal methotrexate, and for all other high risk like CNS, IPA more than 4, more than 3.
It's something wrong with the mic? So you advise.
So in that cases, we give high dose methotrexate for testicular. 3.5 gram per meter square over 3 hours. 2 to 3 cycles. 2 to 3 cycles.
Yeah. So the CNS prophylaxis changed from
intrathecal to high dose.
IV methotrexate, high dose.
High dose.
Okay, right. So now Dr. Priya, so she mentioned that this patient needs a consolidation RT. So when the patient is now being referred to your side, what you will do, and then do we plan RT?
First, I'll advise a PET CT.
Yeah.
And if the patient goes for a complete remission, it's great.
Yeah.
And if there is a residual disease.
And initially the patient had an axial lymph node as well.
Yeah.
Yeah. So you want
to treat that also.
Yeah, exactly. So you want to treat the whole breast with the initially involved lymph nodes.
Yeah.
You want to
uninvolved nodes are not taken.
Pardon?
Uninvolved nodes.
So you will look at pre-chemo. Pre-chemo.
Pre-chemo.
Okay.
And suppose if it is a disease, then I'll escalate the dose to 40 to 55 gray.
Okay, you want to okay. The other day we were discussing
and they're saying that you better go for a partial for breast. Partial breast radiation, that is including the initial tumor volume, pre-chemo volume, and the involved axillary node to the this dose.
You're talking about the
partial response.
So
because if we go for 55 gray, then that's going to harm our OS. So many OS are coming.
The patient goes for complete response, you will treat the whole breast and the initially involved lymph nodes to a dose of 30 to 36, at least 30 gray.
Okay.
And if it is a partial responder, there will be a residual tumor. So gray, and then the tumor you want to boost at least up to 40 gray.
40 gray.
Is that fine?
Yeah.
So that's all about this case. No. So the last case is Just one more case. I think we have 10 minutes left, so we'll finish on time. So this is a 28-year-old lady, para 1, live 1, 14-week pregnant, present with a lump in the left breast. 7 centimeter hard lump in the upper, inner, and outer quadrant with extensive purely orange appearance. Left axillary mass of 2.5 centimeter, matted, and a core biopsy was taken. Invasive ductal carcinoma, grade 3, immunohistochemistry. So she is a pregnant lady, and now the lady visits Dr. Nisha. Then what is this is a pregnant lady coming to you, no?
Okay, this is an unfortunate young lady with a diagnosed malignancy of the breast in the second trimester of her pregnancy. Especially with emphasis on her obstetric as well as a family history for the patient. Explain to the patient and family in detail regarding her situation and what are her priorities, because in this case, hazards involved in the investigations and management. So we have to explain to them in detail regarding all these things. And coming to the investigations, what we suggest is like a bilateral ultrasonogram of the breast.
Yeah.
And MRI without contrast can be suggested in cases, but...
anyway, the initial, it's a T4 disease.
T4 is, so we don't need in that same breast. If you want to have...
So if at all an MRI is needed
if at all we require an MRI based on this case, then we could suggest...
because contrast
can cause like stillbirths and neonatal deaths supposed to be high with the contrast. So only if at all we require, we can go ahead with that. And chest X-ray with like you can keep like
because
shield,
you want to do
AP
a
shield.
workup.
Yeah, you can have as part of this workup, you can have a chest X-ray with an AP shield. And if you suspect liver metastasis or any bone metastasis, we can go ahead with MRI in this case.
Yeah. So you can go with a chest X-ray.
Chest X-ray with an abdominal pelvic shield. Yes, that's what. Yeah.
Right. So workup. Madam, Krishna Madam, like this patient had a core biopsy done actually. So, like pregnant lady, when compared to the non-pregnant, histopathologically, will there any change?
It's a very unfortunate. Pregnancy in breast cancer is usually very high grade type, hormone negative, HER2 positive with a they give in pregnancy associated breast cancer is aberrant expression of several oncogenes, including tumor suppressor genes, genes of apoptosis, transcription regulators, and genes of DNA synthesis. There is a very good high expression of WT1 and P53. So all these contribute to the high grade morphology and the phenotype of the tumor in pregnancy-associated breast cancer, which we do not expect in the usual IDCs of the breast non-pregnancy associated. So it is genetically determined. The exact reason is not known. MicroRNA studies are going on to find out how the tumor cells is changing in its neoplastic biology when there is association. Pregnancy, there are so much of hormonal changes in the body system, and why the genes are aberrantly getting expressed, there is no real explanation for it. But we see the high grade morphology, hormone negativity, HER2 expression, and high proliferative index in pregnancy carcinomas.
Thank you, madam. So pathologically in pregnant lady, the factors are high risk actually. When we think of clinically, and the studies show that treat in the proper way, the results are comparable with a non-pregnant lady. So workup. Now this is a case of carcinoma of the left breast. Clinically T4B, let us take it as an N2, M0, and HER2 positive and hormone positive patient. So, what is your schedule of treatment, Dr. Gopika? What will you advise? She's a locally advanced patient.
So she's a locally advanced breast cancer patient. She definitely needs downstairs. She's in 14 weeks. So she's in second trimester. So chemotherapy can be safely administered. But even though HER2 positive, trastuzumab is not recommended even during pregnancy because it has so many side effects, hydramnios, etc. So the treatment plan will be, I think, neoadjuvant chemotherapy. Then we'll go till 37 weeks and we'll terminate pregnancy. Then after that, surgery for breast cancer. Then maybe after that, adjuvant trastuzumab, and since she's hormone positive, adjuvant hormone. We can plan like that.
Okay. So you are planning for a systemic chemotherapy as neoadjuvant.
Neoadjuvant.
And to how many weeks will you recommend? This is a 3-weekly schedule you are going to follow, no?
Yes. Okay.
In that case, up to how many weeks you will recommend to
up
giving
to 35 weekly, but after that we have to change to weekly regimen because we need a 2 to 3 weeks gap between the delivery and the last chemo to consider this fetal and maternal bone marrow recovery from the myeloma. 3 weeks gap we should give. So at around 35 weeks we should change to weekly schedule, like weekly paclitaxel or something instead of docetaxel.
Yeah. So you already mentioned that you are going to terminate the pregnancy at 37 weeks. So you want to stop at 35 weeks.
Yes.
At the maximum 36.
Maximum 36.
If the patient was getting a weekly. So, okay, that's great. But you don't give a HER2-directed therapy.
No. Trastuzumab is not recommended in any of the trimesters because.
So we always have a worry, like when we think of the chemotherapy, we usually, if it is adriamycin, we give 600 milligram per square meter. We have to take the surface area of the patient. She is a pregnant lady. So do you go with the actual weight or do you want to modify something? Or?
No dose modification is required. We have to calculate chemo dose according to the actual body weight because a lot of large volume of distribution and some of the drugs may be metabolized partly by the placenta also. So we have to not modify the dose. It should be given as that of the
but we
normal
just
patient.
think that that need for a dose modification. And the rationale is that
larger volume of distribution. And partly it will be metabolized by placenta also. So the concentration exposure will be. So we have to give the actual dose itself.
So ultimately the serum level will be almost
similar to that of the non-pregnant.
Okay, that's great. So if she goes in for some neutropenia, can we give some GCSF?
Yes, both we can give short-acting and long-acting. Is safe. Studies have not shown any major congenital abnormalities with GCSF.
Okay, thank you. And now coming to Dr. Priya, very challenging, no? Do you recommend adjuvant RT? This case, is it not that challenging? Huh?
No, I won't advise because she's already 14
Your mic,
weeks.
please. Yeah. Closer, yeah.
She's already 14 weeks pregnant.
Yeah.
Locally advanced breast cancer, and she requires neoadjuvant.
Yeah.
So the neoadjuvant will come to about, if it is a 3-weekly schedule, it will come to up to 24 weeks.
Yeah.
So that will take 24. So 14 plus 24 is going of RT for her.
Not role, actually you don't consider at this point of time.
During this.
Yes.
After that, I'll consider.
Yeah, so you are happy, there is not much confusion. But basically, is radiation safe in pregnancy?
No, I won't advise RT for my patients. Suppose
even if it is very early?
Suppose if it's in between 20, I can get a patient, then I'll advise her all the possibilities of congenital malformations, stillbirth, low birth weight, all those things I'll explain to her. And if she's ready to, I may go for this thing, 26 gray 5 fraction. Sorry.
So coming back to that question again, so my concern is that this lady is a breast cancer patient. She's not having a pelvic cancer. She's a breast cancer patient. Yeah. And she is in her early, maybe 6 weeks or something like that. Okay, it has not come to the abdomen. It's still a pelvic thing. So in a supradiaphragmatic isn't it safe to, and if you are able to monitor the dose
Yeah,
in the first trimester? Can we think about that, no? So, but I think what the literature tells is that you always look into the fetal dose, and if it's MSV, then you can go ahead with the radiation. So
With
as per
pelvic
the,
shielding.
with using a pelvic. So that's what I have understood is that we can go up to the 20 weeks where it doesn't cause. What I am talking is about a breast cancer patient getting a radiation treatment. So the dose is not going to be a big problem for her in a way. Okay, so is away from the pelvis. So in your case, you're lucky that the patient is okay. So
And
if
even
at all,
if it's an early breast cancer, personally, I won't advise RT.
yeah. So if at all you think of radiation treatment in a breast patient, like as for the guidelines, like it is early weeks of pregnancy, rather than still going with a 14, 15, what they recommend is that finish it off in 26 and 5, and rather than the patient come for multiple visit, and so you can plan accordingly. That's the, now, is there any role for endocrine therapy in this particular patient, Dr. Nisha?
No, not during pregnancy. Tamoxifen is contraindicated because anomalies.
So you don't give any endocrine during pregnancy?
During pregnancy, no.
Tamoxifen, definitely you know.
Definitely no tamoxifen.
So the take-home message here is, this is actually, for the surgery is in the first trimester, second trimester, and third trimester surgery is recommended. But radiotherapy in the first trimester, it should be with caution. All not breast cancer alone, all cancer patients basically. It's contraindicated in the second and the third trimester, and postnatal is fine. And chemotherapy first trimester is contraindicated, whereas in the second trimester and the third trimester and postnatal, it is fine. Same way, the endocrine therapy is throughout the pregnancy contraindicated, and we can give post-delivery. So thank you. We took 1 hour, 27 minutes. So thank you so much. Is there any permission?
So we can take in questions.
You are taking one question? Okay, sir.
Regarding the reporting of her invasive carcinoma, I would like to get Dr. Krishna's opinion.
HER2 positivity reporting is done using that guideline only. Positivity, indeterminate and negative cases has to be done, confirmed, followed by FISH. Indeterminate positivity. That is diffuse membranous strong positivity is the correct positivity. Then indeterminate cases, sometimes the staining will not be that prominent. So those cases has to be followed up with FISH studies using reporting scheme, HER2 positivity. We follow that guideline only.
And the incidence of lymph node metastasis in cystosarcoma phylloids.
Cystosarcoma phylloids, the metastatic deposits can take different pattern. Usually the metastatic are sarcomas, usually sarcomas also. Secondary development of breast carcinomas can also occur in a malignant phylloids tumor, which was earlier reported as carcinoma. So both are there. But the usual pattern of metastasis from malignant phylloids is a sarcomatous deposit, and the sarcoma can take any form, fibrosarcoma or even a pleomorphic sarcoma deposit, osteosarcoma deposit. But one point to be remembered by pathologists when reporting malignant phylloids tumor, the liposarcomatous component not taken by WHO as a sarcoma. That is one thing which is little puzzling, but it is there in the new criteria. You can see mesenchymal sarcomatous areas in a malignant Phyllodes tumor, along with the stromal sarcoma area. An area of liposarcoma is not considered as a secondary sarcoma in a Phyllodes tumor. The reason they are not explaining.
Thank you, madam.
One question.
Yeah, please.
Thank you for the nice discussion. It's a very important topic. Rarely we come across, but as all of you told, it is a very aggressive disease, and the vascularity being high during pregnancy and immediate after delivery, the chance of metastasis is also quite high in breast cancer associated with pregnancy. So you said up to 34 weeks and other things, adjuvant treatment after delivery. Some concerns were expressed regarding radiation to the breast. Being an advanced disease, anyhow after delivery the patient requires radiation to the chest. So what about the adjuvant treatment and how long should be continued after delivery?
You're talking about the RT.
RT followed by any maintenance therapy, HER2 and...
Yes, sir. Adjuvant we should give. In this case, we should give trastuzumab adjuvant, and tamoxifen. Since hormone positive, we should give tamoxifen also. Adjuvant we should give.
Is sir's concern is with the breastfeeding?
Breastfeeding?
Breastfeeding is something which cannot be done during chemotherapy. Or when you are giving radiation,
Yes.
breast will become non-functional.
Oh, duration?
Duration, say trastuzumab.
1 year. 1 year.
It's
yes.
Is there any role for any other adjuvant treatment other than hormones and trastuzumab in this case, being an aggressive disease?
No, there is no recommendation anyway. I don't think that's right. Yeah, it all depends on the molecular pathology.
Biology, hormone positive.
So as I think it's our allotted time is over now, shall we move to the next one? Before that, I just want to thank all my team breast, all, especially Krishna madam, such an academician. So really thanking ma'am. All the whole 2 days you are helping us a lot actually, and we are such a vibrant character. We need to appreciate you. At the same time, 3 young beautiful ladies are here. They are also be very, very very expressive, and it was nice for me to share some time with these 4 experts. Thank you so much.
So let me also thank profusely the organizers for giving me the opportunity, and I really enjoyed the sessions here. Especially I could meet many of these young ladies and young gentlemen are my students. It's so rewarding to meet the students after 40 years of teaching in government colleges. Now I am with Sri Gokulam. Very, very happy to participate again. Thank you all once again for the wonderful opportunity and the wonderful hospitality. Thank you all.
Thank you, sir, and our eminent panelists for that very fruitful discussion. I invite Dr. K.L. Jayakumar, Professor and Head, Department of Radiation Oncology, Sri Mookambika Institute of Medical Sciences, Kulashekaram, for felicitating our moderator and our panelists with a memento as a token of appreciation.
I'm also happy that they're all my students, except ma'am.
Thank you, sir. Before we move into the next session, there is an announcement. The attendance sheet for the day is being circulated in the main hall. I request all delegates to kindly mark their attendance. And also, there is a lost phone that has been found. Kindly contact the hotel reception to collect it. So next in line, we have Professor A. Sudhakaran Memorial Oration by Dr. Renu M., Consultant Radiation Oncologist, General Hospital, Thrissur. I invite the speaker onto the dais. To chair the session, I would like to invite Dr. C.S. Madhu, Senior Consultant Oncologist, Luth Hospital, Cochin, and Dr. K.L. Jayakumar, Professor and Head, Department of Radiation Oncology, Sri Mookambika Institute of Medical Sciences, Kulashekaram, onto the dais.
Media player.
Good morning, everybody. Actually, I would like to say a few words about Professor Sudhakaran. Sudhakaran was 3 years senior to me for MBBS at Trivandrum Medical College. But later for MD, we were classmates. He was one of the most brilliant academicians, and he was mostly working in Government Medical College, Calicut. Of course, he has worked in Kottayam, Alleppey medical colleges also. He was with me when we were trying hard to retain the Department of Radiotherapy at Government Medical College, Trivandrum, when RCC came into existence. So together we did a lot of efforts, and if there is a Department of Radiotherapy existing in government medical colleges, it is mainly due to the hard work and struggle which Sudhakaran has put in. He developed a carcinoma at the lower end of esophagus extending to stomach, and he was working, after retirement, he was working in Government Medical College, Kannur. And he treated his malignancy on his own. He did not get advice from anybody else, but as if he is treating any other patient, he underwent treatment, and finally he had his last days in a regional cancer center, where he was looked after well by our Dr. Rajiv and others. He had an excellent palliative treatment there. So I cannot forget the days of togetherness with Professor Sudhakaran, because we worked together in Calicut, we worked together in Trivandrum, we worked together in Kottayam. Dr. Jostom also will be remembering our days. But he was very, very sincere person, and he was also very good in subject and very sincere to patients. And today we have one of his students, Dr. Renu, to present Dr. Sudhakaran Memorial Oration.
Thank you, sir.
Two words about sir. I am fortunate to be associated with Professor Sudhakaran since 1985. He is an excellent academician. I too had the opportunity to work with him for long years at Calicut, Alleppey, etc. And even during his last days, I used to visit his home. And he used to be so jovial, even towards the terminal end of his life. So we are very unfortunate to lose him. So with these few words, we invite one of his favorite students, Dr. Renu.
Thank you, Jagumar sir. Respected Aroicon Kerala Chapter President, Dr. Francis, Secretary Dr. Shabrinath, esteemed faculty, our national leaders, seniors, and my dear fellow colleagues. A warm good morning to all. It's my great privilege and honor to stand before you all today to pay tribute to our beloved Professor, Dr. A. Sudhakaran sir. Thanks to the executive and organizing committee to select me for this duty. As a former student of Sudhakaran sir, I had, during my post-graduation period at JMC Calicut 2002 to 2004, I had a first-hand knowledge on his exceptional teaching skills, outstanding leadership, and unwavering dedication to his students and patients. His guidance and mentorship has shaped me to be the professional I am today. I would like also to express my sincere gratitude to my HODs, Dr. Shashindran sir, Dr. C.S. Madhu, Dr. Jose Tom, and my dear professors, Dr. Jayagumar sir, Ajay Kumar sir, and Tangama madam during my PG period, who all were instrumental in guiding me throughout my career. Today, as we celebrate Dr. Sudhakaran sir's remarkable contribution to the field, I am filled with pride, gratitude, and nostalgia. It's my pleasure to share with you the lessons he gave on oncology and to highlight his endured legacy in the field. Thank you all. These are some photographs with our beloved teachers. I do not have any photo. It was 2002-04 period. I don't have that I missed now at present. This is my mentor, Dr. C.S. Madhu and Jose Tom sir. Let's come to the topic for today. This topic was selected on public health and on oncology perspective. Close the care gap or bridging the gaps in cancer care. Let's start with a short video.
The leading causes of death, touching the lives of millions. Each year. It knows no boundaries, affecting people of every age, gender, and nationality. As one of the leading health challenges of our time, cancer demands a comprehensive approach that spans prevention, early detection, treatment, and survivorship care. Nationally, we have made significant strides in enhancing access to care, in cutting-edge technologies, and promoting research. Programs focused on awareness, equitable healthcare delivery, and robust support systems have been pivotal in addressing the diverse needs of our population. As we stand at the forefront of a new era in cancer care, we remain united in our mission to deliver compassionate, patient-centered solutions that ensure every individual receives the care they deserve. Together, we are building a future where innovation and inclusivity redefine cancer care for generations to come.
Can we continue with the topic? The topic is close the care gap. What's the care gap in cancer care? Care gap is the disparity or inequality between the recommended best treatment and the treatment that is given. To eradicate the cancer care gap, next slide. To eradicate the care gap in as much as possible, globally, the theme of World Cancer Day for 2022 to 2024 was selected as Close the Care Gap. And it was a great challenge, so it was divided into a 3-year campaign. The first year, the aim was understanding and recognizing the challenges in cancer care globally. 2023, it was uniting our voices and taking action. 2024, together we challenged those in power or higher authorities to make policies towards cancer care. Next, the problem statement or the magnitude of the problem. Globally, 20 million new cancer cases are there and 9.7 million cancer deaths. In India, 13.9 lakh cancer cases in 2020, but estimating 15.7 lakhs in 2025. In Kerala, RCC cancer registry shows 11,195 cases in 2020-21, 15,324 by 2023. That's alarming, 36% rise is seen. Review cases 1.5 lakhs to 2.42 lakhs in 3 years. That's again 61% rise in 3 years. Total cases reported in Kerala, 5.7 lakhs in 2020 and 5.9 lakhs in 2022. And Kerala has highest cancer crude rate among our states in all India. That's 169 per 1 lakh population. And these are some paper clippings. It's India. The recent newspaper cutting, that is 12th January 2022, shows that India to see 50K rise per year in breast cancer cases and nearly 1 lakh deaths due to carcinoma breast. In Kerala, the scenario is again something different. Cancer cases are increasing in Kerala. And it seems alarming, but the number says many different things. That is, it is because of our early reporting, screening methods, and perfect data maintaining, and also something related to our habits. That is 16% of cases by smoking or tobacco use, 12% by alcohol use, and obesity, lack of exercise, and also some of our dietary habits, using of red meat more. Now we shall come to the disparities or inequities in cancer care. We have limited access to affordable care. That is, cancer centers are limited and cancer treatment being costly, it is not affordable to many. Delayed diagnosis and treatment. Delay can occur at various stages, that is, from the patient reaching the hospital, lab tests, getting treatment, and also follow-up everywhere. Inequities in treatment outcomes. There are inequities existing globally in treatment outcomes. And lack of awareness and education. Cancer being a preventable disease, awareness is very important. So it is preventable in 1/3 of cases. Limited access to affordable care. Again, we shall divide this into many segments. Poor socioeconomic status. Most of the mortality, so that is more than 70% of deaths occur in low to middle income nations. Costly treatment for cancer. Cancer treatment, be it diagnostic like PET scan, or treatment modalities like radiation, chemotherapy, immunotherapy, all are costly affairs. Limited cancer care centers. Apex cancer centers are limited at urban areas, and people find it difficult to get access to these sites. And geographical differences. Geography different, the treatment outcome differs who you are and where you live. That is, geographically there is a difference in cancer response. Racial differences. Race difference is very important in cancer because genetic makeup differ in different races. So Asian, African and white population have different treatment response. Gender and age. In male persons, that is, most common cancers are CA, prostate, CA lung, oral cavity and oropharyngeal, larynx. In females, the most common cancers are CA breast, CA cervix, CA ovary, and in both gastrointestinal tumors are on the rise. And there are language barriers. Age, as we all know, cancer is an elderly disease, so commonly seen more than 50, 60 years. Delayed diagnosis and treatment, lack of awareness, apprehension on cancer. Cancer is still seen as a deadly disease by public, and we have to feel stigma still persists. Bridging the gaps, we shall come a bit detail into each of this. To affordable care, availability of medical care can be decreased. That is, it should be available at low cost. Utilization of government funds in purchasing medicines or machines can be used. These are the solutions we are doing at present. Utilization of government schemes like CASP, Sugridam, PMJY, and Karunya Benevolent Fund and cancer pension schemes. Purchase of medicine through KMCL or Karunya pharmacies. Karunya pharmacies, there are 74 Karunya pharmacies throughout our state who give branded medicines at very low cost with zero profit. And utilization of NGOs and sponsorship. Next is accessibility. For accessibility, decentralization is a cancer care grid in Kerala. Apex Cancer Centers exists at Regional Cancer Center and Malabar Cancer Center. And we have corporate hospitals, private medical colleges, government medical colleges, and health service sector. Early detection and screening are very important in cancer. Cancer screening camps are done at hospital-based, urban, rural, difficult rural, and even tribal areas. A team of doctors, oncologists, pathologists, surgeons, and cytotechnician, healthcare staff all go together in mobile cancer units, that's mobile units with mammogram and ultrasound facility, so that we can screen carcinoma breast cases with mammogram, and we can have pap smear tests done to screen cancer cervix, and also other screening tests. And we can use NGO support for sponsoring these camps. These are some of our work we do at Health Services Department throughout Kerala. Cancer screening camps at government level and NGOs level. And we give cancer awareness classes to public at each of these camps. Next, we we observe Cancer Day and Cancer Survivors Day in a grand level for cancer awareness at each of our hospitals. And we do collaborate with private and corporate sector for educating our doctors, our own doctors. The third slide is on our collaboration with Amrita Institute to educate the medical officers in our district. Next is the community engagement. We collaborate with community organizations for supporting the patients and families. Here I have to thank what it is done at GH Ernakulam. There is a project Cancer Care who sponsor the cancer patients Nearly 140 patients, needy patients, are getting cancer treatment free of cost. Others are getting cancer medicines, and they help in supporting the super specialty departments in various levels. And we can have the support of media, that is All India Radio or television. Live talks can be done to aware the public on cancers. We have done at All India Radio and Kerala Health Talk. And healthcare workforce development, that's very important. That's a real concern of today. That is, we have minimal workforce and maximum work. So we have to educate and train doctors. And we have tumor board discussions. Tumor board discussions, we join together with other specialties, surgery, pathology, radiology. And we all discuss on doubtful cases and make decisions. And this can reduce the delay in treatment also. Address workforce shortages, improve the quality of care. This is cancer awareness classes we do at our hospital level. And our PG presentation. We have DRP training of 3 months from our medical colleges, both private and government sector. Research and data analysis. Data collection and analysis are very important in cancer for research purposes and to make reasonable policies. These are hospital-based and population-based. Utilization of research funds. Our research need grants from government and other NGOs. And if we develop these, we can do more research works. Here is a slide statistics we have collected from our health service hospitals. In this matter, I have to say something because during the super specialty cadre implementation in 2010 only, we were more strengthened at health service department. We all started our cancer care departments in various districts. I could start cancer department at General Hospital Thrissur, and with Dr. Ansar, I could start cancer department at General Hospital Trivandrum in 2019 also. So we have many hurdles and challenges in developing the cancer care department and for its development, but with hard work and teamwork, we are covering each of these gaps. Just a slight discussion on the statistics. Total, we have treated 1.6 lakhs patients in our OP, and we have given 77,000 chemotherapies during the period of 2024, January to December, at our health service hospitals alone. We have detected 6,000 cases, new cases, at our hospitals, and we have IP facilities. Here we have some shortcomings. We don't have separate cancer care wards at all general or district hospitals. Finding it difficult because our neutropenia patients have to be with the infected cases. That's a real concern, so we maximally treat them at our daycare centers and send them home. They have to daily visit till the neutropenia is corrected. That's a real concern. If you have a separate cancer ward and febrile neutropenia ward, that will be better. Next is palliative and supportive care. Our work doesn't finish with grade stage 1 or 2 cancers. We have stage 3 and 4 cancers who need the pain alleviation and palliative and supportive care, especially for bedridden cases. And most of us oncologists took up palliative training and at the government sector, and we trained our staff also in palliative training. And we started palliative units at our own hospitals with home care visits. It's very beneficial for the patients and their caregivers. Next is on workforce shortages. I am stressing here many times because it is the need of the hour. We have increased patient load. Some hospitals like General Hospital Ernakulam has to treat 200 patients in their OP with 1 or 2 specialists, and we find it very difficult to give quality care, data documentation, everything. So insufficient staffing is a real concern. Burned out among healthcare workers occur due to our work time extends from 8 to 1 p.m. is the work, and or 8 to 3 p.m. Is the work at government medical colleges, but it extends even to 8 p.m. daily, on a daily basis. So there's a burnout among healthcare workers. That's a factor. Next, recruitment and retention challenges. We have to have more post creation, and we have to retain our specialists at general hospital and district hospital where there is a cancer care. Now, at present, some of our specialists are posted even at WNC hospital. That's really a real concern because their service is lost to cancer patients. And so recruitment and retention of our specialists and other staff are a must. Impact on patient care. When the doctor number or staff number is low, it has impact on patient care because patients have to wait for a long time, be it at OP counter, be it at lab, be it our OP, or even for chemotherapy. They have to wait for a long time, for months even. So that has to be shortened and delay has to be shortened. Training and education gaps. We have to educate more of our doctors, and our dream for tomorrow is having clinical oncology at MBBS curriculum, which is mandatory, and have our internship posting at clinical oncology as mandatory. Because our young doctors, after completing even MBBS, not aware of cancer care. And they are afraid to even treat or even to give first aid treatment for cancer patients. So this apprehension has to be alleviated. Next, on innovative technologies. Cancer is a very research-oriented specialty. Day-to-day improvements are there. Telemedicine. We have utilized telemedicine during our COVID pandemic time because our cancer patients couldn't reach apex centers or their cancer centers which are far away from their homes. So we used telemedicine. The reports could be sent to the doctors. Doctors can read them and they can discuss with patients on the treatment protocol. And even we can discuss among ourselves, we can discuss with apex centers or other cancer centers who referred cases to us. Artificial intelligence in healthcare is a future. We should all learn about it and we should implement it at our centers. Next is precision medicine, including genetic counseling. Genetic gene paneling are all the need of the hour, and to treat the patients in their best way and to have best outcome. Next is our vision, that is the policy changes. Some policy changes in cancer care. We have to challenge our higher authorities to have some policy changes, to have more oncologists deputed at our hospitals, more technologies and facilities like radiation facility at our main centers and even health center departments, health services departments. At present, we have only radiation facility in health services only two places. That's General Hospital, Ernakulam, and Tribal at Nallur. And they are giving a great service and can reduce the workload of medical colleges. So if we start radiation machines and facilities at our health services departments also, we shall contribute our service to that field also. And healthcare department, research and data collection. Hereby, let's all work together to decrease the disparities and irregularities and improve patient outcome for a cancer-free world. Thank you. Thank you.
Thank you, Dr. Renu, for bringing out how to decrease the disparities in patient care, at least in our state and also in our country. we all have to understand that Dr. Renu is working in a general hospital, Thrissur. She has been working in General Hospital Thrissur for a long time, and she organized the cancer care services there exceptionally well. And she got many awards also for that. And then she was transferred to Trivandrum, and then she has come back, and she is doing a very good job of treating so many cancer patients. The name of the department and the name of the OP is radiotherapy OP. But there is no radiotherapy. That is one thing which we have to understand. There is actually, it is a clinical oncology service which she is giving. She is giving a lot of chemotherapy. She is treating a lot of HER2 positive breast cancer patients, etc. And when there is a general hospital in the same city where there is a government medical college, when the funds are allotted, if it is to one institute, the government will set apart a limit. Whereas if there are two institutions, definitely there will be more and the patients will be benefited. So today she has brought out the real problems in our health services sector. But we all have to be proud that in Kerala we have this cancer care services rendered rendered through all taluk hospitals and many district hospitals, general hospitals, etc. But there are obstacles coming up because all these posts are, some of these posts are belonging to radio diagnosis, etc. But the thing is, our association can definitely take up these and then represent to the government, and not only that, we can also address the government to start teletherapy services in leading main general hospitals and district hospitals, and also in the newly started government medical colleges. So these things will definitely reduce the care gap, no doubt. And you have given a good account of what are all the problems which you are facing and how the problems can be solved. Thank you.
Thank you, Chairs.
Congratulations.
Thanks all for patient hearing.
Congratulations, Renu, for the excellent oration.
Thank you, sir.
Thank you, ma'am. Thank you, sir. Now I invite Dr. Jostom, Senior Consultant Radiation Oncologist, Caritas Cancer Institute, Kottayam, for felicitating our speaker and our chairpersons with a memento as a token of appreciation.
Hello. Before I go to that handing over the memento, my journey in radiotherapy started in 1981 as a DMRT student in Calicut Medical College. The first day I joined, the first person I got introduced to was Dr. Sudhakaran. He was a tutor in radiology department that time, and I worked with him from that day onwards. Many places, Kottayam, Calicut, Alappuzha, he was working and we used to meet regularly. And it's very sad that he left us so early. And I congratulate Renu for giving an excellent talk on in memory of Dr. Sudhakaran.
I really feel blessed to get this award from my own teachers. All three of them are my mentors, teachers. Thank you, thank you. thank God and God Almighty for this.
Thank you, sir. Thank you, ma'am. Our next session is on treatment sequencing strategies in advanced non-small cell lung cancer by Dr. Roshni S., Additional Professor, Department of Radiation Oncology, RCC Trivandrum. I invite the speaker onto the dais. To chair this session, I would like to invite Dr. Jostom, Senior Consultant Radiation Oncologist, Caritas Cancer Institute, Kottayam, and Dr. R. Shivramakrishnan, Principal, Government Medical College, Kasargod, onto the dais.
Slide change. Next again, touch on up down. Laser point. Proceed on laser.
Good morning, all. My topic is treatment sequencing strategies in advanced non-small cell lung cancer. Before I start my topic, I have to thank the scientific committee, AROI, Kerala, especially Aravind Anand, to give this topic to me. I know that would be a very tedious job because treatment sequencing strategies in advanced non-small cell lung cancer cannot be covered in 30 minutes with so many guidelines. So I tried reading NCC and ESMO NICE, and I thought NICE would be the easiest guidelines to discuss. So I took most of my evidence from the NICE guidelines. So I'll be discussing mainly the NICE guidelines. And one more thing I just have to mention here is, just because that we have just heard the Sudhakaran sir oration, I have to tell that I started my career in 2002 in Kozhikode Medical College, and my first teacher, I joined as a lecturer in Kozhikode Medical College in 2002, and that was under Sudhakaran sir. So I started my career under Sudhakaran sir. So I remember him now because it is a blessing that when you are in the dais and when you just hear that your first teacher was being memorized in a very beautiful way. So I would also thank God to be here just after Sudhakaran sir oration. So what I did was I have tried to make this presentation as simple as possible. So I have made the guidelines into tables so that it is easier for me to convey and for you to understand. So, but I don't know that whether I succeeded, but I'll try my best. So you all know that the treatment of advanced non-small cell lung cancer has evolved from cytotoxic chemotherapy to target specific treatment in the early 2000s. Now we don't talk about chemotherapy alone in lung cancer. We always talk about the targeted therapy, that is a personalized or tailored therapy in lung cancer treatment. So the benefit is that they preferentially kill the malignant cells, but relatively spare the normal cells. So the driver mutations, amongst them, the driver mutations are the most useful biomarker. So these driver mutations, they are somatic gene alteration, and they are not found in germline genome of the host. And they transform the normal cell into a malignant cell. And they impart an oncogene-addicted biology to the transformed cell. So this oncogene addiction leads driver mutation, good biomarkers for selecting patients for target therapy. So that is why we can target the mutation so that the tailored treatment can be given. And matching a specific targeted drug to identify driver mutation for an individual patient leads to increased therapeutic efficacy. As you all know that when you give the targeted therapy, the targeted agent would only act on the target and it would spare the normal cell. So it increases the therapeutic efficacy. And the guideline for the American pathologists, the International Association for the Study of Lung Cancer, and the Association of Molecular Pathologists recommend at least minimum either analysis of EGFR or ALK as a minimum test for from the primary or mets who have adenocarcinoma or who have light smoking or never smoking history. So you do the mutation test in adenocarcinoma patients or patients who have never smoker or light smoking history. So I'll categorize my presentation into squamous and non-squamous. First, I would start with squamous with no target mutation. So with squamous, with PD-L1 less than 50% and no target mutation, the first line recommended is platinum doublet and pembrolizumab plus carbo plus Paclitaxel. So this is what the NICE guideline says. So when you, it doesn't mean that you have to start with pembro, carbo, and Paclitaxel. So I work in a government hospital where you start most of your patients with platinum doublet. So what do you do with the platinum doublet after first when they progresses? What do you do? And if they have money and if you have resources, you would go to the immunotherapy. So pembrolizumab, if PD-L1 is at least more than 1%, and atezolizumab, nivolumab, or docetaxel. So when they progresses on these drugs, what do? And when they progresses on immunotherapy, you can give docetaxel as the third line. If you give docetaxel as the second line, you can go to immunotherapy as the third line. And after pembro, carbo, Paclitaxel as the first line, you can give dosi when they progresses. So that is the guideline says in squamous less than PD-L1 less than 50% and with no target mutation. So what happens to squamous? PD-L1 with more than or equal to 50% and with no target mutation. So the first line would be Paclitaxel, carbo, pembrolizumab, or immunotherapy. You can give either pembrolizumab or atezolizumab. And if you give carbopaclay plus pembrolizumab, the second line would be docetaxel. And if you start with immunotherapy as a first line, you can give platinum doublet as a second line. And if they progresses on second line platinum doublet, you give dosi as the third line. So you have 3 lines of treatment if you start with immunotherapy. So coming to the target mutated tumors, so in non-small cell squamous PD-L1 less than 50% with red fusion positive, the first lines are platinum doublet, pembro carbopaclay, and selpercatinib. So when you give platinum doublet, if they progresses, you can give pembro, atezolizumab, nivolumab, selpercatinib, and docetaxel. And for patients who progresses on pembro, atezolizumab, nivolumab, the third line would be either docetaxel or selpercatinib. So if you're giving selpercatinib as a second line, you can give dosi immunotherapy as a third line. And if you give dosi as a second line, the third line would be immunotherapy, that is pembro, atezolizumab, and nivolumab, and selpercatinib. So you have to understand that nivolumab is approved only in the second line. So all other immunotherapy, pembro and atezolizumab is approved in the first line. And what are the other first lines which you use in red fusion positive tumors? You can use pembro, carbo, paclay as a first line. And if it progresses on this combination, you can either give docetaxel or selpercatinib. So if you give docetaxel as a second line, you can give selpercatinib as a third line. And if you give selpercatinib as a second line, you can give docetaxel as a third line. So it is like just like combining drugs or giving drugs which are not been exposed before. So if you give selpercatinib as a first line, your second line choices would be immunotherapy or docetaxel. So if you give immunotherapy as a second line, the third line you can give is docetaxel. So if you give docetaxel as a second line, then immunotherapy is the third line. So coming to squamous with PD-L1 more than or equal to 50% with red fusion positive. So the first line is pembro carbopaclay, immunotherapy or selpercatinib. So patients progressing on pembro carbopaclay, the second line would be dosi or selpercatinib. And the patients progressing on immunotherapy, the second line would be selpercatinib or platinum doublet. And patients progressing on first line selpercatinib would be platinum doublet. So the third line after docetaxel or selpercatinib is docetaxel. After docetaxel, you can give selpercatinib, or after selpercatinib, you can give docetaxel as a third line. And for second line, if you had given selpercatinib, the third line would be docetaxel. And if you have given platinum doublet as a second line, you can either give selpercatinib or docetaxel. And if the third line is selpercatinib, you can give docetaxel as a fourth line. And if you give docetaxel as a third line, you can give selpercatinib as a fourth line. And after platinum doublet as second line, you can give either immunotherapy or docetaxel. So if you have given immunotherapy as a third line, docetaxel would be the fourth line. And if you have given docetaxel as a third line, it is immunotherapy as a fourth line. And squamous PD-L1 less than 50% with NTRK fusion positive. So the first line would be platinum doublet or pembro carbopaclay. And after first line of platinum doublet, second line you can give pembro, atezolizumab or nivolumab or docetaxel. And after this immunotherapy, if they progresses, the third line would be docetaxel. And if they progresses after docetaxel, you can go to fourth line like entrectinib or laprotractinib. And if the second line after platinum doublet is docetaxel, you can go to immunotherapy as a third line. And after immunotherapy, if they progresses, you can go to entrectinib or laprotractinib as a fourth line. And if you start with pembro carbopaclay as the first line, the second line would be either docetaxel. And if they progresses on docetaxel, it is again third line would be entrectinib or laprotractinib. So if you start with platinum doublet, you can go up to fourth line to entrectinib or laprotractinib. Squamous with PD-L1 more than 50% or equal to 50% and TRK fusion positive. The first line would be pembro carbopaclay. The second line would be dosi, and the third line would be entrectinib or laprotractinib. And if you give pembro or atezolizumab as the first line, your second line can be platinum doublet, followed by docetaxel, followed by entrectinib or laprotractinib. Coming to squamous PD-L1 less than 50% with KRAS G12C positive. The first lines would be platinum doublet or pembro carbopaclay. So after platinum doublet, you can give second line sotorasib, pembrolizumab, nivolumab, or docetaxel. So if you are giving sotorasib as a second line, you can progress. If they progress, you can give third line pembrolizumab, nivolumab, or docetaxel. And if they progresses on immuno or docetaxel, if they progresses on immunotherapy, the fourth line would be docetaxel. If they progresses on docetaxel, the fourth line would be immunotherapy. And after platinum doublet, if you had given immunotherapy as a second line, the third line would be either docetaxel or sotorasib. And if you have given docetaxel as a third line, the fourth line would be sotorasib. And if you give sotorasib as a third line, docetaxel would be the fourth line. And after platinum doublet, if you give docetaxel as a second line, the third line would be sotorasib, pembrolizumab, nivolumab. And if you had given sotorasib as the third line, the fourth line would be immunotherapy. And if you had given immunotherapy as the third line, sotorasib would be the fourth line. After pembro, carbo-paclitaxel, you can give docetaxel or sotorasib as the second line. If docetaxel is given as the second line, sotorasib would be the third line. And if you had given sotorasib, then docetaxel is the third line. So it is like, it is easier to remember. So when you give the certain drugs at the second line, you know that what will come next. And if it is PD-L1 more than or equal to 50%, the first line would be immunotherapy like pembro or atezolizumab or pembro carbo plus paclitaxel. So if it is pembro carbo plus paclitaxel, the second line would be docetaxel or sotorasib. And if it is docetaxel as the second line, then sotorasib as the third line. Sotorasib as the second line, third line would be docetaxel. And if it is immunotherapy, pembro atezolizumab as a first line, you can give platinum doublet or sotorasib as a second line. And if you are giving platinum doublet as a second line, you can give either docetaxel or sotorasib as a third line. Or if you are given sotorasib as a second line, you can either give docetaxel or platinum doublet as a third line. And after docetaxel or sotorasib at the third line, you can give, if you are given docetaxel as a third line, then sotorasib as a fourth line. If you are giving sotorasib as a third line, then docetaxel as the fourth line. So coming to PD-L1 less than 50% is MET exon 14 skipping. The first lines approved are pembro, carbo-paclitaxel, tepotinib, and platinum doublet. So if you are giving pembro, carbo-paclitaxel as a first line, it should be followed by either docetaxel or tepotinib. And if you are giving second line docetaxel, then third line would be tepotinib. And if you are giving second line as tepotinib, then third line is docetaxel. And if you are starting with tepotinib, the second line would be platinum doublet, followed by docetaxel or immunotherapy. And if you are giving docetaxel as a third line, then you can give immuno, that is pembro, atezolizumab, or nivolumab as a fourth line. And if you are giving immunotherapy as a third line, then you can give docetaxel as a fourth line. So when you start with platinum doublet, the second line choices are pembro, atezolizumab, nivolumab, tepotinib, and docetaxel. So if you are giving immunotherapy as a second line, the third line would be docetaxel. And if you're giving tepotinib, then the third line would be pembro, atezolizumab, nivolumab. And if you're giving pembro, atezolizumab, nivolumab as a third line, the fourth line would be docetaxel. And if you're giving second line as docetaxel after platinum doublet, the third line would be tepotinib, and followed by, if it progresses, you can give immunotherapy like pembro, atezolizumab, or nivolumab. And now PD-L1 more than or equal to 50%, the first line treatment would be pembro, carbo-paclitaxel, or pembro or atezolizumab, or tepotinib. So if you're giving pembro, carbo-paclitaxel as a first line, the second line could be tepotinib or docetaxel. So second line tepotinib followed by docetaxel as a third line, and second line docetaxel can be followed by tepotinib as the third line. So but if you start with immunotherapy like pembro or atezolizumab as the first line, the second line could be platinum doublet or tepotinib. If you're giving platinum doublet as a second line, you can either give docetaxel or tepotinib as a third line. And if you're giving tepotinib as a second line, you can give either platinum doublet or docetaxel as a third line. So if you start with tepotinib, the second line could be platinum doublet, followed by immunotherapy like pembro, atezolizumab, or nivolumab, and docetaxel. So if you're giving pembro, atezolizumab, nivolumab as a third line, you can give fourth line docetaxel. So if you're giving third line docetaxel, you can give pembro, atezolizumab, nivolumab as the fourth line. So coming to squamous PD-L1 less than 50%, BRAF V600 positive, first line would be platinum doublet, pembro, carbo-paclitaxel, or dabrafenib plus trametinib. So if you give platinum doublet as a first line, the second line could be immunotherapy like pembro, atazole, nivolumab or docetaxel. The second line pembro, atazole, nivolumab would be followed by docetaxel as a third line. And if you give second line docetaxel, then pembro, atazole, nivolumab would be the third line. And if you start with pembro, carbopaclay as the first line, the second line would be docetaxel. And if you start with dabrafenib plus trametinib as the first line, the second line would be platinum doublet, which would be followed by pembro, atazole, nivolumab or docetaxel. So if you give immunotherapy as a third line, it can be followed by docetaxel as a fourth line. And if you give docetaxel as a third line, it could be followed by pembro, atazole, nivolumab as the fourth line. So PDL1 more than or equal to 50%. The first line would be pembro, carbopaclay, pembro plus pembrolizumab or atazolizumab or dabrafenib plus trametinib. And the first line pembro, carbopaclay, the second line would be docetaxel. And if you're giving immunotherapy like pembro or atazole, the second line would be platinum doublet, which can be followed by docetaxel as a third line. And if you start with dabrafenib or trametinib as the first line, the second line could be platinum doublet, which could be followed by either pembro, atazole or nivolumab as a third line or docetaxel. So if you're giving pembro, atazole, nivolumab as the third line, the fourth line would be docetaxel. So if you give docetaxel as a third line, you can either give pembro, atazole or nivolumab as the fourth line. Coming to PDL1 less than 50%, this is non-squamous with no target mutation. So these are the first line which are approved are platinum doublet followed by pemetrexed maintenance, CDP plus pemetrexed followed by pemetrexed maintenance. That is either platinum with any drug, that is gemcitabine or paclitaxel, or platinum plus pemetrexed. All the platinum doublet could be followed by pemetrexed maintenance. And this other first line approved are carbopaclay plus atazolizumab plus bevacizumab or platinum plus pemetrexed plus pembrolizumab or pembro, atazole or nivolumab. So this for the non-squamous we do have more options. And if you are giving platinum doublet followed by pemetrexed maintenance as the first line, the second line you could think of would be either immunotherapy like pembro, atazole or nivolumab or docetaxel or docetaxel plus nintedanib. So if you're giving immunotherapy as the second line, you can consider dosi or dosi plus nintedanib as the third line. So if you are giving any platinum plus pemetrexed followed by pemetrexed maintenance, you can consider second line pembro, atazole, nivolumab, docetaxel or docetaxel plus nintedanib as the second line. And if you're giving carbopaclay, atazole plus bevacizumab as the first line, your second line you can consider would be dosi or docetaxel plus nintedanib. So if you are giving platinum plus pemetrexed plus pembrolizumab, the second line you can consider is docetaxel or docetaxel plus nintedanib. And if you're giving immunotherapy as the first line, then docetaxel or docetaxel plus nintedanib. And non-squamous PDL1 more than or equal to 50% with no target mutation. The first line you can consider is platinum plus pemetrexed plus pembrolizumab or pembrolizumab or atazolizumab. So if you're giving platinum plus pemetrexed plus pembrolizumab as the first line, the second line you can consider would be dosi or dosi plus nintedanib. So if you're giving pembro or atazole as the first line, the second line you can consider would be platinum doublet followed by pemetrexed maintenance or platinum plus pemetrexed followed by pemetrexed maintenance. So either you can combine pemetrexed with platinum or you can combine pemetrexed with any drug like gemcitabine or paclitaxel. So if you're giving these drugs of platinum doublet or platinum pemetrexed followed by pemetrexed maintenance as the second line, the third line you can think of would be docetaxel or docetaxel plus nintedanib. So coming to non-squamous PDL1 less than 50% RET fusion positive. The first line approved at platinum doublet, platinum plus pemetrexed, followed by both can be followed by pemetrexed maintenance, and paclay, carbo, atazole plus bevacizumab, platinum plus pemetrexed plus pembrolizumab or selpercatinib. And the second line followed by the platinum doublet followed by pemetrexed maintenance would be either immunotherapy like pembro, atazole, or nivolumab, docetaxel plus nintedanib, or selpercatinib. So if you are giving immunotherapy as a second line, you can give third line docetaxel plus nintedanib, or selpercatinib as a third line. So if you are giving docetaxel as a third line, you can give selpercatinib as a fourth line. And if you're giving selpercatinib as a third line, you can give either docetaxel or docetaxel plus nintedanib as a fourth line. So when you give Paclitaxel plus carbo plus atazole plus bevacizumab, or platinum plus pemetrexed plus pembrolizumab as a first line, you can consider docetaxel or docetaxel plus nintedanib or selpercatinib as a second line. So if you give dosi plus nintedanib as a second line, you can give selpercatinib as a third line. So if you give selpercatinib as a second line, you can give dosi or dosi plus nintedanib as a third line. So if you start with selpercatinib, you can give platinum doublet or platinum plus pemetrexed followed by maintenance of pemetrexed, or Paclitaxel plus carbo plus atazole plus bevacizumab as the second line. So platinum doublet followed by pemetrexed maintenance could be followed by either immunotherapy or dosi plus nintedanib. So if you are giving immunotherapy as a third line, you can consider dosi or dosi plus nintedanib as the fourth line. So if you're giving Paclitaxel plus carbo plus atazole plus bevacizumab as a second line, you can consider docetaxel or docetaxel plus nintedanib as the third line. So coming to PD-L1 more than or equal to 50% positive, the first line are platinum pemetrexed plus pembrolizumab or atazolizumab or selpercatinib. So if you're giving platinum pemetrexed plus pembrolizumab, you can consider docetaxel plus nintedanib or selpercatinib as a second line, or docetaxel and docetaxel nintedanib. If they progresses, you can consider selpercatinib as a third line. And for those who had taken selpercatinib as a second line, you can consider dosi or dosi plus nintedanib as a third line. So if you start with pembrolizumab or atazolizumab, the second line you can give is platinum doublet or platinum plus pemetrexed followed by pemetrexed maintenance or selpercatinib as a second line. So if you're giving platinum doublet or platinum pemetrexed followed by pemetrexed maintenance as a second line, you can consider dosi or dosi plus nintedanib or selpercatinib as a third line. So if you consider selpercatinib as a second line, you can give docetaxel as a third line. So if you are giving dosi or dosi plus nintedanib as a third line, you can consider selpercatinib as a fourth line. So if you are giving selpercatinib as a third line, you can consider dosi or dosi plus nintedanib as a fourth line. So if you start with selpercatinib, if they progresses, you can consider Paclitaxel, carbo plus atazole plus bevacizumab as a second line, or platinum doublet or platinum plus pemetrexed followed by pemetrexed maintenance. And for the third line, after Paclitaxel, carbo, atazole and bevacizumab, you can consider dosi plus nintedanib. And if you are giving platinum doublet or platinum pemetrexed followed by pemetrexed maintenance, the third line you can consider would be pembro, atazole or nivolumab, or docetaxel plus nintedanib. So if you're giving immunotherapy as a third line, you can consider dosi plus nintedanib as the fourth line. And coming to KRAS G12C positive in PD-L1 less than 50%. The first line are platinum doublet followed by pemetrexed maintenance, or platinum plus pemetrexed followed by pemetrexed maintenance, or carbo, Paclitaxel, atazole plus bevacizumab, or platinum plus pemetrexed plus pembrolizumab. So if you give platinum doublet followed by pemetrexed maintenance, the second line you can give is pembro, atazole, nivolumab, or docetaxel plus nintedanib, or selpercatinib. So if you're giving immunotherapy as a second line, you can consider dosi plus nintedanib, or sotorasib as a third line. So if you're giving dosi plus nintedanib as a second line, you can give sotorasib as a third line. So if you're giving sotorasib as a third line, you can consider dosi plus nintedanib as a fourth line. And if you're starting with carbo, Paclitaxel, atazole plus bevacizumab, second line would be dosi plus nintedanib or sotorasib. So if you're giving second line as dosi plus nintedanib, the third line would be sotorasib. So if you're giving second line sotorasib, the third line would be dosi plus nintedanib. So platinum plus pemetrexed is pembrolizumab was given as the first line. The second line you can consider is docetaxel plus nintedanib or sotorasib. And the third line would be after dosi or docetaxel nintedanib would be sotorasib. And after second line of sotorasib, the third line would be dosi plus nintedanib. And for non-squamous PD-L1 more than or equal to 50%, the first line would be platinum pemetrexed plus pembrolizumab or pembrolizumab plus atezolizumab. And for patients with platinum plus pemetrexed plus pembrolizumab, the second line you consider would be dosi plus nintedanib or sotorasib. The second line, dosi or docetaxel plus nintedanib would be followed by third line as sotorasib. And if sotorasib is given as the second line, the third line would be docetaxel or docetaxel plus nintedanib. So if you start with immunotherapy like pembro or atezolizumab, the second line would be platinum doublet or platinum plus pemetrexed, which both would be followed by pemetrexed maintenance. And if they progresses, you can start either sotorasib or docetaxel plus nintedanib. So after immunotherapy, if they progresses, you can also consider sotorasib as the second line. And if they progresses on sotorasib, you can consider docetaxel as the third line. And if the patients on third line sotorasib progresses, you can consider dosi plus nintedanib as a fourth line. Or if they are on third line docetaxel or docetaxel plus nintedanib, you can consider fourth line sotorasib. And for patients with PD-L1 less than 50%, NTRK fusion positive, the first line are platinum doublet or platinum plus pemetrexed, both followed by pemetrexed maintenance, or Paclitaxel plus carbo plus atezolizumab plus bevacizumab, or platinum plus pemetrexed plus pembrolizumab. The second line after platinum doublet followed by pemetrexed maintenance would be either pembro, atezolizumab or nivolumab, or docetaxel plus nintedanib. So if you're giving second line immunotherapy, the third line would be docetaxel or docetaxel plus nintedanib, which could be followed by entrectinib or larotrectinib. If you're giving docetaxel or docetaxel plus nintedanib as a second line after platinum, then you can consider entrectinib or larotrectinib as a third line. So if you are starting with Paclitaxel plus carbo plus atezolizumab plus bevacizumab, the second line you can consider would be docetaxel plus nintedanib followed by entrectinib or larotrectinib. So if you start with platinum plus pemetrexed plus pembrolizumab, the second line you can consider would be docetaxel or docetaxel plus nintedanib. And if you're giving docetaxel or docetaxel nintedanib as a second line, you can consider entrectinib or larotrectinib as a third line. So for patients with PD-L1 more than or equal to 50%, NTRK fusion positive, the first line would be platinum plus pemetrexed plus pembrolizumab or pembrolizumab or atezolizumab. So if you consider first line as platinum plus pemetrexed plus pembrolizumab, the second line you can consider would be docetaxel or docetaxel plus nintedanib. So if the progress is on either of these, you can start with entrectinib or larotrectinib as a third line. So if you start with immunotherapy as a first line, the second line you can consider would be platinum doublet or platinum plus pemetrexed, both followed by pemetrexed maintenance. And if the progress is on these, you can consider dosi or dosi plus nintedanib, which could be followed by entrectinib or larotrectinib as the fourth line. Coming to MET exon 14 skipping positive for PD-L1 less than 50%, you start the first line proved out platinum doublet, platinum plus pemetrexed followed by pemetrexed maintenance, or carbo plus Paclitaxel plus atezolizumab plus bevacizumab, or platinum plus pemetrexed plus pembrolizumab, or tepotinib. So if you give platinum doublet followed by pemetrexed maintenance, the second line would be either immunotherapy or docetaxel plus nintedanib or tepotinib. So if you give immunotherapy as a second line, you can consider dosi plus nintedanib or tepotinib as the third line. And for patients with dosi or docetaxel plus nintedanib as a third line, you can consider tepotinib as a fourth line. So if you consider tepotinib as a third line, you can consider dosi or dosi plus nintedanib as a fourth line. So if you're giving docetaxel or docetaxel plus nintedanib as the second line after platinum doublet and pemetrexed maintenance, you can consider tepotinib as a third line. If you consider second line as tepotinib, then it could be followed by dosi or dosi plus nintedanib as a third line. So if you're giving carboplatin atezolizumab plus bevacizumab or platinum plus pemetrexed plus pembrolizumab, the second line you can consider would be docetaxel plus nintedanib or tepotinib. So if you're giving dosi or dosi plus nintedanib as a second line, you can consider tepotinib as a third line. And if you give tepotinib as a second line, you can consider dosi plus nintedanib as a third line. And if you start with tepotinib, what you can give after as a second line would be platinum doublet or platinum plus pemetrexed, which both could be followed by pemetrexed maintenance, or Paclitaxel, carbo, atezolizumab plus bevacizumab. So if you're giving platinum doublet or platinum pemetrexed followed by pemetrexed maintenance as the second line, you can consider immunotherapy as a third line. So if you consider Paclitaxel, carbo, atezolizumab plus bevacizumab as a second line, you can give dosi dose plus nintedanib as the third line. So if you're giving pembrolizumab, atezolizumab, or nivolumab as a third line, you can consider dose or dose plus nintedanib as a fourth line. So coming to PD-L1 more than or equal to 50% positive, the first line are platinum plus pemetrexed plus pembrolizumab, or pembrolizumab, or atezolizumab, or tepotinib. So if it is platinum plus pemetrexed plus pembrolizumab, the second line would be dose plus nintedanib, or tepotinib. So if you're giving second line docetaxel or docetaxel plus nintedanib, the third line would be tepotinib. So if you're giving second line tepotinib, the third line would be dose or dose plus nintedanib. So if you're giving immunotherapy as a first line, the second line you can consider would be platinum doublet or platinum plus pemetrexed, both followed by pemetrexed maintenance or tepotinib. So if you're giving platinum doublet followed by pemetrexed maintenance as a second line, the third line would be dose or dose plus nintedanib or tepotinib. And if you're giving dose or dose plus nintedanib as a third line, the fourth line could be tepotinib. And if you're giving tepotinib as a third line, then you can proceed to dose or docetaxel plus nintedanib as a fourth line. So if you're giving tepotinib after immunotherapy as a second line, you can consider dose or dose plus nintedanib as a third line. So if you start with tepotinib, your second line choices would be carboplatin, atezolizumab plus bevacizumab, or platinum doublet, or platinum plus pemetrexed followed by pemetrexed maintenance. And for carboplatin, atezolizumab plus bevacizumab, third line treatment you would consider would be docetaxel or docetaxel plus nintedanib. So if it is platinum doublet plus pemetrexed, or platinum doublet or platinum plus pemetrexed followed by pemetrexed maintenance, the third line would be either immunotherapy, that is pembro, atezolizumab, nivolumab, or docetaxel plus nintedanib. So if you're giving immunotherapy as the third line, you can consider dose or docetaxel plus nintedanib as a fourth line. So for coming to PD-L1 less than 50%, BRAF V600 positive, the first line would be platinum doublet or platinum plus pemetrexed followed by pemetrexed maintenance, or carboplatin, atezolizumab plus bevacizumab, or platinum plus pemetrexed plus pembrolizumab, or dabrafenib plus trametinib. So if you're giving platinum doublet or platinum plus pemetrexed followed by pemetrexed maintenance, the second line would be either immunotherapy, that is pembro, atezolizumab, or nivolumab, or dose plus nintedanib. So if you're giving second line immunotherapy, third line you can consider would be dose or dose plus nintedanib. So if you're giving carboplatin, atezolizumab, bevacizumab, or platinum pemetrexed pembro as a first line, you can consider dose or dose plus nintedanib as the second line. And if you're giving dabrafenib plus trametinib as a first line, the second line you can consider would be platinum doublet, platinum plus pemetrexed, both followed by pemetrexed maintenance, or carboplatin, atezolizumab plus bevacizumab. So for patients with platinum doublet or platinum plus pemetrexed followed by pemetrexed maintenance as second line, if they progresses, you can consider immunotherapy like pembro, atezolizumab, nivolumab, or docetaxel plus nintedanib. And if you're giving immunotherapy as a third line, you can consider dose or dose plus nintedanib as the fourth line. For patients with PD-L1 more than or equal to 50%, the first line would be platinum plus pembrolizumab, immunotherapy like pembro, atezolizumab, or dabrafenib plus trametinib. For the patients who progresses on platinum plus pemetrexed plus pembrolizumab, the second line would be either docetaxel or docetaxel plus nintedanib. So patients with pembro or atezolizumab, when they progresses, you can consider platinum doublet or platinum plus pemetrexed followed by pemetrexed maintenance. And if they progresses, you can consider dose or dose plus nintedanib as the third line. If you are starting with dabrafenib plus trametinib as the first line, you can consider carbo plus paclitaxel plus atezolizumab plus bevacizumab as the second line, or platinum doublet or platinum plus pemetrexed followed by pemetrexed maintenance. And if they progresses on carbo plus paclitaxel plus atezolizumab plus bevacizumab as the second line, you can consider either docetaxel or docetaxel plus nintedanib as the third line. If you are giving platinum doublet or platinum plus pemetrexed followed by pemetrexed maintenance as the second line, you can consider either immunotherapy like pembro, atezolizumab, nivolumab, or docetaxel plus nintedanib. So if you are giving immunotherapy as the third line, you can consider dose plus nintedanib as the fourth line. Coming to non-small cell non-squamous easier for positive patients. So what are the first line it could give is gefitinib, afatinib, erlotinib, dacomatinib, and osimertinib. So for patients with T790 mutation positive, osimertinib is a drug of choice. And after osimertinib, if they progresses, what do you do? Then you can give platinum doublet as a third line, or platinum plus pemetrexed followed by pemetrexed maintenance as a third line, or you can consider carbo plus paclitaxel plus atezolizumab plus bevacizumab in the third line. So if they progresses after platinum doublet and platinum plus pemetrexed, you can consider immunotherapy like pembro, atazole, nivoli, or docetaxel plus nintedanib. So if you're giving carbo plus paclitaxel plus atazole plus bevacizumab as a third line after osimertinib, then you can consider dosi or dosi plus nintedanib in the fourth line. And if you start with platinum doublet followed by pemetrexed maintenance, the second line you can consider would be afatinib, erlotinib, which could be followed by pembro, atazole, nivolumab, or docetaxel plus nintedanib. And if they progresses after the immunotherapy, you can consider dosi or dosi plus nintedanib in the fourth line. And coming to the specific mutation which you would see, exon 19 deletion and exon 21 L858R, the drug choices would be osimertinib or osimertinib plus chemotherapy or amivantamab plus lasatinib. And for unusual mutation like S7681, 6861Q, G719X, the treatment choices would be afatinib or osimertinib. That is unusual mutations, so you could consider afatinib or osimertinib, not geftinib. And for exon 20 insertion, you should give platinum doublet plus amivantamab. And for non-small cell, non-squamous, ALK-positive patient, the first line you can give is crizotinib, ceritinib, alectinib, brigatinib, platinum doublet, or carbo, pacli, atazole plus bevacizumab. If you're giving crizotinib as a first line, you can consider ceritinib or brigatinib in the second line. So if you're giving ceritinib or brigatinib in the second line, the third line you would consider would be lorlatinib. And if they progresses on lorlatinib, the fourth line would be platinum doublet or platinum pemetrexed followed by pemetrexed maintenance. So if they progresses on platinum doublet followed by pemetrexed maintenance, fifth line you can give immunotherapy, dosi or dosi plus nintedanib. So if you're giving carbo, pacli, atazole plus bevacizumab, you can give fifth line dosi plus nintedanib as a fifth line. And after immunotherapy, sixth line you can consider dosi plus nintedanib or immunotherapy. And if you give ceritinib, alectinib, brigatinib as the first line, you can consider second line lorlatinib, third line platinum doublet or platinum plus pemetrexed, followed by immunotherapy, dosi plus nintedanib, or immunotherapy if given on fourth line, it could be followed by dosi plus nintedanib. If you start with platinum doublet or carboplatin, atazole, bevacizumab, you can consider crizotinib, brigatinib, docetaxel plus nintedanib as the second line. And if crizotinib as the second line, you can consider ceritinib or brigatinib in the third line. If you give brigatinib as the second line, you can consider immunotherapy in the third line. If crizotinib or brigatinib as the third line, you can consider immunotherapy in the fourth line. If you consider immunotherapy in the third line, you can give dosi plus nintedanib in the fourth line. And if it is pembro, atazole, nivo, in the fourth line, you can consider dosi plus nintedanib in the fifth line. ROS1 positive, first line, crizotinib or entrectinib, which it could be followed by platinum doublet or platinum plus pemetrexed, or carbo-pacli, atazole plus bevacizumab in the second line. If platinum doublet in second line, you can consider immunotherapy, docetaxel plus nintedanib in the third line. And if it is carbo-pacli, atazole, bevacizumab, you can give dosi plus nintedanib in the third line. If it is immunotherapy in the third line, you could give dosi plus nintedanib in the fourth line. So that's it. Thank you. So I know that this was too confusing, so I tried to make it a table so that it would be easier for me to present and for you to understand. So it is like the permutation and combination and the, so what drug you had already given, what you have not exposed the patient. So it is like a game. So when you start with platinum doublet, you would have in some cases, you could go up to fifth or sixth line. So it doesn't mean that you have to consider all these treatment options for patients, but for patients who can afford, and if the patient resources are not drained, and if you have the resources in your hospital, and if the patients could afford, because you know that the immunotherapy is one of the most expensive, because people talk about immunotherapy all the time for all the cancers. But still, it's very expensive for the patient. For a doctor who work in Regional Cancer Center, Trivandrum, so we don't come across those kind of patients very often. So that is very rare minority of the patients who would ask for immunotherapy who can afford. But these are the choices you have in your kitty when you discuss with them. So you have to discuss all the treatment options with patients who could afford all these regimens. So I think, so these are, you have to follow some guidelines. So there are guidelines and there are evidences in the treatment of lung cancer. And I think treatment of lung cancer has evolved a lot from systemic chemotherapy to very tailored targeted treatment.
Thank you, Dr. Roshni. Very confusing talk.
Yes, sir. It was when I started preparing it, it was like, because I was reading all the guidelines, I couldn't make even a clue out of it. So it was very tedious job too.
20 years back, things were very easy.
Very easy.
A patient with lung cancer comes and we'll tell them that you will live less than 1 year. That was the end of it. Now, within half an hour, she couldn't finish the treatment options.
Sir.
And there are a lot of options, and lung cancer has become a chronic disease now. If not, you cannot cure it. It is a chronic disease. Okay, any questions from the audience?
Roshni, thank you for the very nice presentation. I think you have to make a spreadsheet so that everybody can keep it under their table.
I think, sir, that is the best option, because even though I had read it many times, I could still can't remember the third line, fourth line, fifth line, or sixth line. So what I know is what I do in my clinics. That's all I remember. And as new products are coming up, it is impossible for a human being to remember all those drugs which are there. So I think it is easier for us to make a spreadsheet, like you have said, and put it in front of us and just read it out.
Just go through
I think Dr. Aravind might be knowing that in UK, that's what they do. They don't memorize anything.
Yes.
You know, yeah.
No, it is not practically possible.
That is not humanly possible. No,
yes. And giving the proper guidance.
Why would we? We don't have to. We don't have to. No, it is just, we just had to know that these are the, because now I know that there are 6 lines sometimes. So now I know that if I have to discuss with the patient, I have to have this in front of me and would discuss with the patient. And I think that's all you can do. That's all you can do. It's because you are not treating lung cancer alone. So on our other sides, there are new products are coming in. You can't remember anything. No.
Roshni, 2-3 questions. Say when we treat a patient, normally as sir said previously 6 months without treatment, with the treatment 1 year. Now it has become prolonged. So I would like to ask you 2-3 questions. One, basically most of the things have the first line chemotherapy. Say after some time the patient can recur. Say if the recurrence interval is long, say maybe 1 year or 2 years, are you justified in still trying the same thing as you do in?
Very much, sir. Very much. Because it is like if the disease-free interval is more than even 6 months, you can still give platinum, because that's all we do. Because even after 1 year or 2 years, if they recur, you can challenge with the same chemotherapy.
Yes.
You can always do that. So and rebiopsy should be done also.
Yes, for change in histology.
Change in histology or mutation or anything, because it is always advisable to do a rebiopsy.
Sir, we are running short of time.
One more question. What is the duration of immunotherapy normally, even as first line?
It is always till progression, sir. Always.
So it's a
continuous process. So that is, I have made it a point that if there's resources of the patient, you have to discuss with the patient the exact cost. You should not start with immunotherapy before telling them that it is going to be there for 1 or 1.5 years, because you have to discuss the exact cost. So only if the patient can afford, you should not financially drain the patient.
So it is still progression.
Yes, sir.
Yeah. Thank you, Dr. Roshni, for the fantastic presentation. You can share we'll share the slides with others so they can make a spreadsheet or ready reckoner in their future practice. Thank you so much. Shall we move to the next session now? Thank you.
So thank you so much, ma'am. Now I invite Dr. Manoj Gupta, sir, Professor and HOD, Department of Radiation Oncology, AIMS Rishikesh, to felicitate our speaker and the chairpersons with a memento as a token of our appreciation. Next, we have in line a session on radiobiology of normal tissue injuries and clinical implication. I request Sir, Professor Department of Radiation Oncology, AIMS Rishikesh, for sharing his views on the topic, radiobiology of normal tissue injuries and its clinical implications.
Can I have my presentation, please? So as expected, I think my session is the last session, and very few residents I can see. So because I have prepared my presentation especially for postgraduate residents. Anyway, so can I ask a postgraduate resident who are sitting on the back, if they can move on the front chairs, I think. So though it's a last presentation, but let me tell you that as a radiation oncologist, when we plan any radiation treatment, the first thing in our mind is that how to save normal tissues. So we should not do any harm, and that is also the part of Hippocratic Oath, that we should not do any harm. So this is a very important, the issue in our radiation practice, that what are the radiobiology of the normal tissue complication, and how we can how we can exploit this radiobiology in our day-to-day clinical practice. So for residents, I would like to discuss some basics of radiobiology, and that is the cell survival curve, so that you can understand the clinical implications of these normal tissue radiobiology in our day-to-day practice in a better way. So if you see, I think we all are familiar that the target inside the cell are the two strands of DNA molecule, what we call two critical sites. And in order to bring death to the cell, we need to deactivate the two critical sites or two strands of DNA molecule. We also know that there are two processes of cell killing taking place simultaneously. One is predominantly seen in low dose region, and other predominantly seen in high dose region. So what happens in low dose region, that as a result of one radiation events, both the critical sites are hit simultaneously, resulting into cell death. And this kind of cell death is known as single hit kill, or linear cell kill, or alpha cell kill. And here the effect is equal to alpha D, and the cell survival curve, because of this predominant process of cell kill, is a curvy structure or continuously bending, and we call it shoulder. In high dose region, what happens that as a result of single radiation events, one critical site is hit, leading to sublethal damage. As a result of second radiation events, the other critical site is hit, leading to other subclinical damage, and then interaction of these two subclinical damage result into cell death. And this kind of cell death is known as double hit kill or quadratic cell kill or beta cell kill, and effect is equal to beta D square, and the cell survival curve because of this predominant process of the cell kill is a straight line. And the total cell kill will be sum of these two processes of cell kill, that is alpha D plus beta D square, and this model is known as linear quadratic model. So we all are familiar with this model. Now what is alpha beta ratio? To understand alpha beta ratio, if you draw a tangent through the initial curvy portion of the cell survival curve, then it will divide the graph into two portions. The upper portion will reflect the cell kill because of linear hit or alpha cell kill. The lower portion will denote the cell kill because of quadratic hit or beta cell kill. Now what I'm going to do, I'm going to move from low dose region to high dose region, and we will see how these two processes of the cell kill contribute in overall cell kill. So when you are in the low dose region, you will appreciate that only contribution in cell kill is by alpha cell kill and no contribution by beta cell kill. When you increase the dose, still you see only contribution by linear hit and no contribution by quadratic hit. When you further increase the dose, now you will appreciate that red arrow also start appearing, which means that at this dose level, the beta cell also contribute in overall cell kill. And when you further increase the dose, the contribution by beta keeps increasing. Now at this dose, what are you observing? That the height of two arrows are exactly similar, which means that at this dose, the cell kill by linear hit is equal to cell kill by quadratic hit. And we know the linear hit is alpha D, which will be equal to beta D square at this dose. And when you bring beta on the left hand side, D on the right hand side, you get alpha beta ratio is equal to dose. So alpha beta ratio is nothing but the dose at which two processes of the cell kill becomes equal. And when you further increase the dose, the contribution by beta component increases exponentially. So from this graph, we can say that in low dose region, the predominant process of the cell kill is alpha, and in high dose region, the predominant process of the cell kill is beta. Now, depending upon the alpha beta ratio, the body tissue have been divided into two categories. We all are familiar with this, that is late reacting tissue and early reacting tissue. Both have different shape of the cell survival curve. If you focus on the left panel, the cell survival curve in late reacting tissue is something like this, where shoulder is more curvy. And you draw a tangent to the initial curvy portion and try to find out the dose at which two processes of the cell kill will become equal, and you will appreciate that it is achieved at a lower dose, and that is the reason that alpha beta ratio for late reacting tissue is low, which ranges from 1 gray to 7 gray. We take an average of 3 gray. If you focus on the right panel, this is the shape of the cell survival curve of early reacting tissue, where the shoulder is less curvy. Again, draw a tangent through the initial curvy portion and try to find out the dose at which two processes of the cell kill become equal, and you will appreciate that this is achieved at a higher dose, and that is why the alpha beta ratio for early reacting tissue are higher. It ranges from 6 gray to 10 gray or 15 gray, and we take an average of 10 gray. We also know the concept of biological effective dose, because this is more important than our physical dose, and this is equal to ND, 1 plus D divided by alpha beta ratio. N is dose per fraction, the N is number of fraction, D is the dose per fraction. So this together will form the total dose. D is again dose per fraction, and alpha beta ratio we have already discussed and understood. So with this background knowledge, now let us come to our main topic, that is factor affecting the normal tissue injury. And for our clinical understanding and clinical purpose, I have taken the normal tissue as the spinal cord. So these are the various factors which affects the normal tissue injuries. First three factors are very important, so I will just focus in more detail the first three factors, and if time permits, the rest of the two factors I will explain. So let us first look how fraction size or dose per fraction affects the normal tissue injuries. So we have already understood that, I think this is not working, but anyway. So let me have the laser here. Right. So if you see, the upper panel belongs to late reacting tissue where you have low alpha beta ratio and the shoulder is more curvy. The lower panel is early reacting tissue. So what this curve says that suppose if you are giving D1 dose per fraction. So what happens that when you give D1 dose per fraction, then it reduces the survival fraction in both type of tissue. When you increase the dose per fraction from D1 to D2, it will further reduce the survival fraction in both type of tissue. But you will observe that reduction in survival fraction for late reacting tissue is much more as compared to early reacting tissue. So this is a very important fact that when you increase the dose per fraction, the damage to late reacting tissues are more than early reacting tissue. Or vice versa, or the other way around, we can say that when you reduce the dose per fraction, it will spare the late reacting tissue more. And again, I am taking the example of spinal cord. So now this concept, how it helps in our clinical setting. Now, how do we treat head and neck cancer? There are two ways by which we can treat head and neck cancer. One is with non-IMRT plan, what we use shrinking field technique. We all practice that. The second is IMRT plan. So suppose if you treat with non-IMRT plan by shrinking field technique, we usually treat first the primary disease as well as whole neck, and we deliver a dose, say 46 gray in 23 fractions. The 46 gray is considered to be the tolerance limit of the spinal cord. But if you calculate the BED, after that what we do, we bring the posterior border anteriorly to omit the spinal cord so that rest of the doses can be delivered to rest of the tumor burden. So if you calculate the BED of this regime to the spinal cord, the BED comes out to be 77. So we can say that 77 BED is the tolerance limit to the spinal cord. So this is with non-IMRT plan. Now with IMRT plan, we generate a single plan, especially in SIB, and we deliver, say, suppose 70 gray in 35 fraction. And you put a constraint, same physical dose constraint to the spinal cord, that is 46 gray. But remember that this time, this 46 gray has to be delivered in 35 fraction, because you have planned a single plan that is to be delivered in 35 fraction. So the dose per fraction now, if you calculate, it is much less than 2 gray per fraction. So you have reduced the dose per fraction to the spinal cord from 2 gray per fraction to 1.31 gray per fraction. And we have seen in previous slide that when you reduce the dose per fraction, it will spare the late reacting tissue more, which means that now spinal cord damage will be less. And if you calculate the BED with this fractionation regime of spinal cord, then BED is something like 66. So tolerance BED is 77, but with IMRT, you are giving much less than the tolerance BED. Inadvertently, you are not aware, but inadvertently, you are very well giving less than tolerance BED to the spinal cord. And as I told you, that BED is more important than any physical dose. So, and this will have an implication during re-irradiation. So you still have a window period as far as spinal cord is concerned, just by changing your technique from shrinking field technique to IMRT technique. So we can say that irradiation with IMRT is better than non-IMRT plan, especially if you feel that patient may come with relapse and you have to re-irradiate these patients. So that's that thing you should keep in your mind. So first take-home message is that upfront IMRT treatment is better than non-IMRT treatment, especially for re-irradiation. The second factor is overall treatment time. So how overall treatment time affects the normal tissue injuries. We all know that body tissue remains in the steady state, which means that number of cells being produced at any given point of time are equal to number of cells being dying at that point of time, which means that cell loss factor will be 1 and tissue will not grow. But as a result of some injury, whether it is a physical injury or a radiation injury, the steady state goes into a regenerative state, which is known as accelerated repopulation. And here the number of cells produced are more than number of cells dying at any given point of time. Cell loss factor is less than 1 and tissue will grow. So this overall treatment time affects the normal tissue injury because of this regenerative activity, what we call accelerated repopulation. Now how this accelerated repopulation affects the two types of tissues, that is the early reacting tissue and normal and the late reacting tissue. So just look at the screen. So this is basically two types of toxicity, the acute toxicity and late toxicity. For acute toxicity, I have taken the mucositis, say grade 2 mucositis. For late reacting tissue, the myelopathy, say grade 1 myelopathy. So this graph shows the relationship between the dose versus overall treatment time. So what it says, if you just focus first on the early reacting tissue. So if the overall treatment time is 4 days, then you require roughly 20 gray to have a grade 2 mucositis. But when the overall treatment time is 10 days, then you require 25 gray for the same grade of mucositis, right? So if you give 20 gray, or if you prolong the treatment time for 20 gray radiation from 4 days to 10 days, now you will see that there will not be any grade 2 mucositis, because for 10 days you require 25 gray, while you are giving just 20 gray. So there will not be any grade 2 mucositis, but if the same dose is delivered in 4 days, there will be grade 2 mucositis. So we can say that prolonging the overall treatment time is spare the early reacting tissue. Now if you look at the late reacting tissue, the spinal cord, whether overall treatment time is 4 days or overall treatment time is 10 days, the dose required to cause grade 1 myelopathy will remain the same. So there will not be any change. So we can say that prolonging the overall treatment time will not spare the late reacting tissue. So the message is that during radiation treatment, the accelerated repopulation or regenerative activity only seen in early reacting tissue and not in late reacting tissue. But if you carefully see the late reacting tissue graph, you will appreciate that at later part, this curve again start rising similar to early reacting tissue. And this indicates that some accelerated repopulation or regenerative activity seen in late reacting tissue, that is spinal cord. So that is important to understand how the radiation injury in spinal cord is recovered. Now there is one bad thing and one good thing with the spinal cord. The bad thing is that the spinal cord remember the irradiated doses. But the good thing is that with time, cord start forgetting the irradiated doses. So the dose of radiation which can be delivered during re-radiation safely to the spinal cord will depend upon two factors. One, how much dose is remembered by the spinal cord at the time of re-radiation. And this in turn will depend how much dose is given to the spinal cord during first irradiation, or what is the priming dose to the spinal cord during the first irradiation. And second factor, the time interval between the two irradiations. So these are the two factors. So I will discuss one by one. So first let us look at remembered dose to the spinal cord. Now this graph shows the relationship between the priming dose versus the remembered dose on this axis. So what it says that suppose if you give 100% of the tolerance dose to the spinal cord, then, and we consider say 45 or 46 gray as the tolerance dose. So it will remember 100%, and it will not be possible to re-radiate if spinal cord is coming into your field. But if you deliver say 70% of the 46 gray or the tolerance dose to the spinal cord, then it will only remember 20%. And you can still irradiate spinal cord with 80% of the tolerance dose. Or if you deliver 40% of the tolerance dose to the spinal cord during first irradiation, then it forgets everything, almost everything, and you can still irradiate spinal cord with 95% of the tolerance dose. But remember, these figures are obtained on the animal model, so we cannot, we cannot extrapolate these figures to human being. But certainly the message which this experiment is giving us, that if you give less than tolerance dose to the spinal cord will forget in due course of time, and you will be in a safer position to re-radiate the spinal cord. So that is a message given by this experiment. The second factor is time interval between the two irradiation. Suppose the time interval is 100 days, then you can deliver 20% of the tolerance dose during second irradiation. But if time interval is increased from 100 to 200 days, then you can deliver more than 20% or 40% around again of the tolerance dose to the spinal cord. So this is basically the radiobiology of the recovery of the spinal cord. And this is again one paper which shows that as the time interval increases, the percentage recovery increases from 50% to 70%. So with this background, if I ask you, the same patient is planned. In one plan, the constraint was put to 45 gray. In other plan, the constraint to spinal cord is kept 31 gray without compromising the target coverage. The same patients, two different plans. So which one is better? So certainly the bottom plan is better. Why? Because here you have delivered the 100% tolerance dose to spinal cord, and it will be difficult for re-radiation of this patient or with this plan. But here you have delivered only 70% of the tolerance dose. So with time, the cord will start forgetting, and if patient needs re-radiation, it will be much easier to re-radiate. So naturally, this plan is better. So second important take-home message in your clinical practice is that try to achieve less than tolerance dose to the spinal cord. We always put a constraint of 45 gray when we plan IMRT. But ask physicists to keep the doses less than 45 gray. And if you remember, yesterday the case was presented of buccal mucosa where irradiation was delivered. And if you remember, during first irradiation, the cord dose was around 35 gray, so much less than the tolerance dose. So in such scenario, we are in a very safe position if patient require re-irradiation. Now coming to the same slide with IMRT or non-IMRT. So with IMRT, even if it is not possible, in some patient to achieve less than tolerance dose to the spinal cord. But if the first irradiation is by IMRT, not by shrinking field technique or 3D conformal radiotherapy. So if you remember, inadvertently you are giving less than the tolerance dose. So less than almost 14% less than BED you are delivering with IMRT as compared to 3D conformal RT. So even during first plan, spinal cord dose cannot be kept lower than 45 gray. But if you are treating with IMRT, I think again you are in a safer position to re-irradiate if these patients will require re-irradiation. And remember that head and neck cancer, you see, majority of the cases we see in stage 3 locally advanced disease where the treatment of choice is chemoradiotherapy. But all these locally advanced patients, if you follow, almost 2/3 of them will come with relapse. And only 20 to 30% of these relapsed cancer patients are eligible for salvage surgery. Majority of these patients will come to you for re-irradiation. So this knowledge is very important in your clinical practice. Then coming on to the time interval between the two fractions, because yesterday in the same discussion, you must have heard that re-irradiation is much safer with when you treat with hyperfractionation, like RTOG trials of re-irradiation. But when you are giving two fractions in a day, you have to again keep in mind the radiobiology of how it affects the late reacting tissue if time interval is less than 24 hours or if time interval is more than 24 hours. So we know that when you give two fraction with some time interval in between the two, what happens that shoulder reappear, right? Because of the repair of the sublethal damage, right? The shoulder will reappear, and this sublethal damage is repaired completely between the two fraction, and these cells act as a fresh shell without any radiation injury. If you look at the effect of time interval between two fraction on survival fraction, now as the time interval increases, the survival fraction keeps increasing because of the repair of the sublethal damage, right? After that, there is a plateau, which means that there is a time limit for the repair of the sublethal damage, and which is usually considered as 5 to 6 hours. Though two types of tissue have different speed of repair of the sublethal damage. Now remember that now I am talking of sublethal damage repair, not the repopulation. Both are different things, right? So this is a repair of the sublethal damage. In early reacting tissue, they are repaired fast, and total repair time is 4 to 8 hours. While late reacting tissue, the repair process is slow and total repair time is more than 12 hours. Again, this has an implication in our clinical practice. How? Again, try to understand the repair in spinal cord, repair of the sublethal damage. Now, in spinal cord, the half-life of repair of the sublethal damage is around 4 hours, and total repair takes 24 hours, right? So, if you look at the
cell survival curve of 2 fraction to the spinal cord given below less than 24 hours. So naturally, less than 24 hours means that still some cells needs repair, or they have not repaired because they require more than 24 hours. So naturally, if you deliver 2 fractions with 24 or more than 24 hours, then full recovery is taking place because of repair of sublethal damage, and curves get much shallower. And if you reduce the survival fraction to the same point, then you have to deliver, say, different doses depending upon what is the time interval between the 2 fractions, whether it is less than 24 hours or it is more than 24 hours. And suppose this level of reduction in survival fraction is a tolerance, right? So if you reduce the interfraction interval from 24 hours to 6 to 8 hours, as we used in hyperfractionated radiotherapy. So remember, you have to reduce the tolerance to the spinal cord by 10 to 15% because repair of the sublethal damage has not been completed. So if you are delivering 2 fractions with 24 hours interval, the tolerance is considered as 45 gray, but if you are delivering less than 24 hours or like hyperfractionated radiotherapy, the tolerance should be 40 gray. So remember this point, that don't give 45 gray constraint to the spinal cord if you are using hyperfractionation. Otherwise, you will end up having a lot of myelopathies. So the third point is the total cumulative dose to the spinal cord to be reduced by 10%, especially in hyperfractionated radiotherapy. Now same time interval have an implication in our now SBRT, right? SBRT usually you like prostate, just 5 fractions. Yesterday you listened, 5 fractions, SBRT. So the question is whether these 5 fractions should be delivered every day or on alternate day. So there are evidences because again with the same concept, we know that for late reacting tissue, the repair of the sublethal damage takes 12 to 24 hours, right? So there are evidence which suggest that if you give on alternate day, then the late reactions in blood, especially in prostate, the late reaction in bladder and rectum are less as compared to patients who receive 5 fractions every day. And these are usually evidence-based. They have shown that rectal toxicity showed a significant reduction as well as even the bladder toxicity is lower in patients who are given alternate day SBRT program rather than every day. So these are the main important point, which affects our day-to-day clinical practice. And I think, do I have some more time? Okay. So just to very quickly how turnover or proliferative, what we mean by turnover and organization of functional subunit. So proliferative status or turnover time is basically reflects the manifestation of radiation injury, right? Means that if you irradiate today some organ, we all know that the injury is not manifested immediately. There are some gap. After that, the radiation injury will be manifested. So this basically is the function of the turnover of that particular organ, turnover of the cells or renewal of the cells of the particular organ. For example, I have taken an example of jejunum villi. We know that at the base of villi we have crypts, and in crypts we have stem cells which divides and gives rise to progenitor cells. Progenitor cells again divide and gives rise to differentiated cells, which are basically the functional cells. And these functional cells then are supplied to the villi, where they live their life and then die and shed into the lumen. And this process continues. But the lifespan of this differentiated or functional cell is 14 days. So what happens that if you irradiate the jejunum villi, it will depopulate the progenitor cell, but the already produced differentiated cells are there to supply to the villi. So that is the reason that there will not be any immediate dysfunction of the villi. And these cells will keep providing the differentiated cells to the villi, and we know that there are 14 days, it takes 14 days, or lifespan is 14 days. So for 14 days, there will not be any symptoms. But after 14 days, there will be symptoms in the form of, diarrhea. So the important point here is that you should not confuse the tolerance with the latency. Latency you have understood because of turnover. Tolerance is tolerance of the organ. For example, I have taken the bone marrow and the gut. the normal tissue complication probability of the bone marrow and the gut, and the curve more on the left side, more sensitive it is to the radiation. So bone marrow, we all know, is more sensitive to the radiation than gut. But if you look at the latency of the bone marrow, is 30 days as compared to gut, which is 14 days. So what does it mean? That if there is a whole body irradiation, the diarrhea will appear first rather than pancytopenia, though bone marrow is more sensitive than gut. So the message is that if clinical manifestation of radiation injury appears early, it does not mean that the organ is more sensitive and has lost tolerance. So another important message is that early manifestation of radiation injury has no connection with tolerance of the organ. So these are the main points which I wanted to highlight, and I will stop at this point of time. So thank you very much, and if there is any question, please. Thank you.
Thank you so much, sir, for your excellent presentation.
Thank you, Manoj sir, for the excellent presentation. Sir, how do genetic and molecular factors contribute to individual variations in radiosensitivity?
Pardon, can you repeat that?
How do genetic and molecular factors contribute to individual variations in radiosensitivity?
So genetic and molecular factors are very important. Yeah, they affect the radiation sensitivity. For example, especially in breast cancer, the triple negative breast cancer, right? They have a genetic defect of DNA repair. They lack DNA repair, right? And that is why that triple negative breast cancer are most sensitive among all the breast cancer group, molecular subtype, right? And that is evidence based. If you see the hypofractionated trial, there was a post hoc analysis. They try to find out that which among all the 4 molecular subtype, which molecular subtype shown best result after post-operative radiotherapy, and they found that triple negative breast cancer have shown best result in reference to local tumor control among all the 4 molecular subtype, and this was attributed to the fact that they cannot repair the DNA damage, so they are more sensitive, right? Similarly, in head and neck cancer, EGFR, patients who have EGFR more than median, right? They are highly proliferative diseases. So if you reduce the overall treatment time, you take care of the accelerated repopulation. So that is the group. Not all the group of head and neck cancer will benefit with, say, 6 fractions per day or slight, reducing the overall treatment time. But patient with EGFR mutation, more than median, they will be benefited. So these are the preliminary, data which are coming up and which reflect that, yes, molecular and genetic plays an important role. So in future, we can see more, insight into this.
Thank you, sir.
Thank you, sir, for your excellent presentation. Is there any clarification from our PG students? Any doubt clearance? Then we'll wind up the section. Thank you.
Thank you so much, sir, once again. Now I invite Dr. K.L. Jayagumar, sir, Professor and HOD, Radiation Oncology, Mookambika Institute of Medical Sciences, to felicitate the speaker and the chairpersons with a memento as a token of our appreciation. Thank you, Jayagumar, sir. Soon we will start our valedictory function and the prize distribution. All of you please stay back for the same.
ഇതിൻ്റെ കഴിഞ്ഞു.
We will begin the valedictory function soon. I invite Dr. Prema Madam, Head of the Department GMC Thrissur, Organizing Chairperson Aroicon 2026, Dr. KL Jayagumar, Professor and HOD, Mugambige Institute of Medical Sciences, Oncology Department, Professor Madhu Sir, President-elect Aroy, Dr. Manoj Gupta Sir, HOD and Professor, Radiation Oncology AIMS Rishikesh, Dr. R. Shivramakrishnan Sir, Principal GMC Kasaragod, Dr. Nivin Bose, Consultant Oncologist, General Hospital, and Dr. Shabrinath Sir, Consultant Oncologist, GH Pala. I welcome the respected dignitaries to the dais and to occupy their seats. Now I invite Dr. Prema Madam, Organizing Chairperson Aroicon 2026 and also Professor and HOD GMC Thrissur for the welcome address.
Good morning. Respected President Aroy Kerala, respected President National Aroy Manoj Gupta Sir, and Treasurer and Secretary Aroy Kerala, and my dear friends and colleagues. ഇന്ന് ഈ വാലിഡിറ്റി ഫംഗ്ഷന് വെൽക്കം ചെയ്യാനാണ് എല്ലാവരെയും ഈ ഫംഗ്ഷനിലേക്ക് ഞാൻ വെൽക്കം ചെയ്യുന്നു. അടുത്ത വർഷം എറോയി കേരള കോൺഫറൻസ് തൃശ്ശൂർ മെഡിക്കൽ കോളേജ് റേഡിയേഷൻ ഓങ്കോളജി ഡിപ്പാർട്ട്മെൻറ്റാണ് നടത്താനായിട്ട് എറോയി ഏൽപ്പിച്ചിട്ടുള്ളത്. അപ്പോൾ ആ ഫങ്ഷൻ അതിൻ്റെ വെന്യൂ ഇപ്പോൾ ഡിസൈഡ് ചെയ്തിട്ടില്ല, നമ്മൾ പിന്നീട് അറിയിക്കാം. സംവർ നിയർ തൃശ്ശൂർ ആയിരിക്കും ഉണ്ടാവുക. അതിന് എല്ലാവരുടെയും സഹായ സഹകരണങ്ങൾ വേണം എന്ന് ഞാൻ അപേക്ഷിക്കുകയാണ്. അത് ഇതിനേക്കാളും ഒന്നുകൂടി ബെറ്റർ ആയ രീതിയിൽ നടത്താമെന്നാണ് വിചാരിക്കുന്നത്. അതിന് എറോയി കേരളയുടെ എല്ലാ സപ്പോർട്ടും ഉണ്ടാവണം. ജയകുമാർ സാറിനോടും ശബരി നബിൻ ബോസിനോടും ഈ അവസാനിപ്പിക്കുന്നു.
Thank you, ma'am. Now I invite Dr. KL Jayagumar Sir, Professor and HOD, Radiation Oncology, Mugambige Institute of Medical Sciences, for the presidential address.
Good afternoon. This is the last session of the day. To make this Aroicon 2025 happen, we have been struggling for a long time. almost 6 months of continuous work, starting from the venue and the location, then the scientific program, formation of various committees, subcommittees, that is the academic, transport, then our selection of topics, then souvenir committee. So many committees have been formed. And I congratulate and I am so much delighted to associate with our secretary, Dr. Shabari. He has been working throughout day and night for this. And we do have our meeting. As a school headmaster, he used to call each and every one of us in the evening, every alternate day for the last 2 months to make this happen so wonderfully organized. So thank you, Shabari, for doing such a wonderful job. It's not a single person's work, it's a combined effort of all of us to make this success so much. The academic feast was excellent. The location, the hospitality is par excellence. And I also take this opportunity to give a special mention to Dr. Arun Shankar, who made the souvenir so beautifully done, almost single-handedly. And each time he calls all of us for contribution, their details and all. No, he is calling each and every person personally to make this happen. So this souvenir, first time we have made the souvenir as part of the association. Thank you, Arun. And I should thank each one of you, especially the team leaders, Aravind and his team, to make the academic session so beautifully done. The speakers, hand-picked speakers selection, and also the deliberations are excellent. And other committees, subcommittees, the transport committee, it's a very, very difficult job for them to do catering these transportation facilities across Kerala and outside Kerala also. They did well, and it's not easy for them to, it's not an easy place, accessible place for them to come alone. So they have made such a good arrangements for all of you to reach here in time and do well. And I should thank each and every one of you to be here for successful completion of this Arroy 2025. And I also hope that the coming Arroy that is at, happen to be at Trichur will be more. And I wish all success for the coming Arroy also. With that, I'm concluding. This is my first appearance before you as the president of Arroy Kerala chapter. Thank you so much. Okay, thank you very much.
Thank you, sir. Now I invite Dr. Manoj Gupta, sir, Professor and HOD, Radiation Oncology, AIMS Rishikesh, for the inauguration of the valedictory function and the inaugural address.
So once again, thank you very much, Kerala chapter, for having invited me on this conference. This, as I told you yesterday, this was my second conference, and I really enjoyed both time, last time as well as this time. And what I could observe that the attendance, especially in your conferences, are pretty good. And not only, during first day or initial part of the conference, but still I can see almost half full hall or more than half full hall. So that shows their commitment and their sincerity, especially the residents and other senior faculty members. The scientific program was designed excellently. I must congratulate Dr. Arvind, and all the deliberation were really fantastic, and especially the panel discussions plus some what was the name, the couple, yes, that was something new for me, and I really enjoyed all these
format of the scientific program. Regarding the postgraduate students, I have been involved in judging their paper, and I can say that the quality of their work was really very, very good here. So all credit again goes to the teachers and their mentors. So with these words, thank you very much, and I wish, long live Kerala chapter.
Thank you so much, sir, for the inaugural address. Next, I invite. Okay.
Forgot to mention the main two heroes, the Sabri and Dr. Francis. Thank you.
Next, I invite Dr. Nibin Boo, sir, Consultant Oncologist, General Hospital, Kollam, for the felicitation address.
Respected dignitaries on the dais, my dear friends. Actually, these are the final hours of CanCon 2025. ആക്ച്വലി നമ്മൾ 2023 ഒരു വാഗമണിലൊരു കോൺഫറൻസ് നടത്തിയിരുന്നു. അത് ഇമ്മീഡിയറ്റായിട്ട് നമ്മൾ പെട്ടെന്ന് പ്ലാൻ ചെയ്തൊരു കോൺഫറൻസ് ആയിരുന്നു. അതിനുശേഷം നമ്മൾ ഇത്രയും എലാബറേറ്റ് ആയിട്ടൊരു പ്ലാൻ ചെയ്ത കോൺഫറൻസാണ് മൂന്നാറിൽ നടത്തിയത്. ഒത്തിരി കമ്മിറ്റികൾ, സബ് കമ്മിറ്റികൾ എല്ലാം ഉണ്ടായിരുന്നു. പക്ഷേ ഇത് ഏറ്റവും വലിയൊരു സക്സസ് ആവാനുള്ള ഏറ്റവും വലിയ റീസൺ പാർട്ടിസിപ്പേഷനാണ്. കഴിഞ്ഞ തവണ നമുക്കൊരു 120 രജിസ്ട്രേഷൻസാണ് ഉണ്ടായിരുന്നത്. സോ ദിസ് ടൈം വി ഹാവ് 142 രജിസ്ട്രേഷൻസ് ആൻഡ് മോർ ദാൻ 200 പാർട്ടിസിപ്പൻസ്. സോ ആക്ച്വലി ഇൻ ദാറ്റ് വ്യൂ ദിസ് കോൺഫറൻസ് ഈസ് എ ഹ്യൂജ് സക്സസ്. ആൻഡ് എല്ലാ ഓർഗനൈസിംഗ് കമ്മിറ്റികളും വളരെ കോർഡിനേറ്റ് ആയിട്ട് വർക്ക് ചെയ്തു. എസ്പെഷ്യലി അക്കാഡമിക് കമ്മിറ്റി, Aravind sir. As like Manoj Gupta sir mentioned that there's new types of discussion, that is couple discussion, and all these things are introduced. I think it's the first time introducing in the history of any conference. Okay. Then especially I want to mention two names, that Vishnu and Abraham. They did an excellent job. Because ഞാൻ വന്നിട്ട് ഇതുവരെ അവരൊരു സ്ഥലത്ത് ഇരിക്കുന്നത് ഞാൻ കണ്ടിട്ടില്ല. സോ അപ്രീഷിയേറ്റ് ബോത്ത് ഓഫ് യു ഫോർ യുവർ എക്സലൻറ്റ് വർക്ക്. ദെൻ അരുൺ ശങ്കർ സാറ്. സാറ് എനിക്ക് തോന്നുന്നൊരു വിത്തിൻ ലിമിറ്റഡ് ടൈം, വിത്തിൻ ലിമിറ്റഡ് റിസോഴ്സസ് ആണ് സാർ ആ പ്രോഗ്രാം, സോവനീർ ഇറക്കിയത്. ആൻഡ് സാർ, സ്പെഷ്യൽ താങ്ക്സ് ടു യുവർ സിൻസിയർ ഹാർഡ് വർക്ക്. ദെൻ അതിൽ ആസ് എ ട്രഷറർ എന്നുള്ള രീതിയിൽ എനിക്ക് തോന്നുന്നത് ഏറ്റവും കുറവ് എമൗണ്ട് എനിക്ക് ഒരു ബില്ല് തന്ന കമ്മിറ്റി സാറാണ്. അപ്പോൾ ജസ്റ്റ് വി ഡിസ്കസ് യെസ്റ്റർഡേ, ജേർണലിൻ്റെ കാര്യം പറയുകയാണെങ്കിൽ അത് വലിയ ഫിനാൻഷ്യൽ കമ്മിറ്റ്മെൻ്റ് ഇല്ലാതെ നടത്തിക്കൊണ്ട് പോകാൻ പറ്റുന്ന ഒരാൾ അരുൺ ശങ്കർ സാർ ആയിരിക്കുമെന്നാണ് എനിക്ക് തോന്നുന്നത്. ദെൻ travel committee, that was excellent, especially Dr. Anoop and Dr. Dilip. അവർ ഒരു ട്രാവൽ കമ്മിറ്റി ആൻഡ് മാത്രമായിട്ടല്ല അവർ വർക്ക് ചെയ്തത്. അവർ എല്ലാ ഇൻഡിവിജ്വലായിട്ട് ഓരോ ഫാക്കൽറ്റിനെ അവർ പേഴ്സണലായിട്ട് വിളിച്ച്, എനിക്ക് അനൂപ് ഈസ് നോട്ട് സ്റ്റിൽ ഹിയർ ബിക്കോസ് ആക്ച്വലി അനൂപ് എനിക്ക് തോന്നുന്നു താഴെ ബസ്സിൽ എല്ലാവരെയും കയറ്റി യാത്രയൊക്കെയാണ്. അപ്പോൾ അത്രയും സിൻസിയറിറ്റിയോടെയാണ് അവർ വർക്ക് ചെയ്തത്. ദെൻ രജിസ്ട്രേഷൻ കമ്മിറ്റി, ജോസ്റ്റോം സാർ എസ്പെഷ്യലി. ദെൻ എല്ലാവരും, ഞാൻ അവരുടെ പേരെടുത്ത് പറയാൻ പറ്റില്ല, ഓരോരുത്തരുടെ ആയിട്ട് പറയുന്നില്ല, എല്ലാവരും നല്ല കോർഡിനേറ്റ് ചെയ്ത് വർക്ക് ചെയ്തു. സോ ഫൈനലി ദ എൻഡ് റിസൾട്ട് ഈസ്, ഐ തിങ്ക് ദിസ് കോൺഫറൻസ് ഈസ് എ ഹ്യൂജ് സക്സസ്. ബസ്സിൽ അയക്കാൻ പോയതാണ്, ദിലീപ് ബസ് കയറ്റിവിടും. നമ്മൾ ഇനിയും കോൺഫറൻസുകൾ നടത്തും. 2026 മാഡം, പ്രേമ മാഡം എഗ്രി ചെയ്തിട്ടുണ്ട്. സോ ഇഫ് ഇറ്റ് ഈസ് നോട്ട് അതിരപ്പള്ളി, ആക്ച്വലി ഐ തിങ്ക് ഇറ്റ്സ് ആൻ എൻഡ് ഫോർ ദിസ് ഡെസ്റ്റിനേഷൻ കോൺഫറൻസ്. അതിരപ്പള്ളിയാണെന്നുണ്ടെങ്കിൽ വീണ്ടും ഡെസ്റ്റിനേഷൻ കോൺഫറൻസ് കണ്ടിന്യൂ ചെയ്യും. ഓക്കെ, ആക്ച്വലി ഇറ്റ്സ് ക്വൈറ്റ് ഡിഫിക്കൽട്ട് ടു കണ്ടക്ട് എ conference in a place like Munnar, Vagaman. It's not like that of Cochin and Trivandrum, because ഇവിടെ നിന്ന് എല്ലാവരെയും ഇത്രയധികം ആളുകളെ ഇവിടെ എത്തിക്കുക എന്ന് പറയുന്നത് ഇറ്റ്സ് എ ഹ്യൂജ് ടാസ്ക്. അത് എല്ലാവരും വളരെ ഭംഗിയായിട്ട് ചെയ്തു. ദെൻ അക്കാഡമിക് പ്രോഗ്രാംസിന് ക്വിസും അതുപോലെ നമുക്ക് ഡിബേറ്റും എല്ലാം വളരെ നന്നായിട്ട് തന്നെ കണ്ടക്ട് ചെയ്യാൻ പറ്റി. നെക്സ്റ്റ് ഇയറിലും എല്ലാവരും ഇതുപോലെ തന്നെ വർക്ക് ചെയ്യണം. അടുത്ത കോൺഫറൻസും ഒരു വലിയ സക്സസ് ആവട്ടെ. പ്രേമ മാഡം പോയോ? മാഡം ഇവിടെ ഉണ്ട്. അടുത്ത കോൺഫറൻസും ഒരു വലിയ സക്സസ് ആവണം. അതിന് മാഡത്തിൻ്റെ എല്ലാ കോൺട്രിബ്യൂഷനും ഉണ്ടായിരിക്കണം. സോ വൺസ് അഗൈൻ thanking all of you to coming all this way to Munnar to attend this conference and making it a big success, because success of each conference depends upon the participation. So in that way, thanking all of you. Thank you.
Thank you so much, sir. Next is the award ceremony. I now invite Dr. Aravind Desanan, Professor and HOD, Radiation Oncology, Government Medical College, Thiruvananthapuram, also the chairperson of the scientific committee, Kerala Aroicon 2025, to declare the results of the various competition events and prize distribution.
Okay. Thank you once again, the Aroy Kerala chapter, for giving me an opportunity to be the chairperson of this scientific committee. So we have tried our level best to do things, because we had a very good, dynamic, young, energetic team. So first of all, I appreciate my whole team for the same. So coming to the winners of this various competition, we really had a tough time to find out the winners. And even the results also will reflect that, because for certain events we had tie. It was being shared by one or two teams like that. So first it was a quiz competition. That was the first one. And I just start with the third. Before that, I just mentioned that only few of you are here. So those who are here will give the prizes. For the others, regarding the certificate, the winner certificate will be sent as email, and their other, the prizes will be kept with the other committees. The executive committee will keep it. And with regard to your prize money or the cash prizes, after the executive committee, they will meet and they will let you know what your cash prizes are. So now those who are here, just come and collect the prizes. And I think for the quiz, we'll start the third go to Government Medical College, Trivandrum, Dr. Don Andrews and Dr. Shweta. So I think they are not here. So we'll move on to the second prize to Government Medical College, Kozhikode, that is Dr. Najia Suleiman and Dr. Fasana. I think they are also not here. And the first prize, the winners to Amrita Institute of Medical Science, Kochi, Dr. Gautam Balaji and Dr. Sevika Nagarjun. I think they are here. Please come on. Yeah. Dr. Manoj Gupta sir and Dr. Jayakumar sir, please hand over the prizes to the Gautam Balaji and Dr. Sevika Nagarjunan. Congratulations, both of you. Expecting good oncologists from them. Okay, right. Now, coming to the debate, we had two teams as the first, the winners. The first is, both are the first winners. Dr. Darshan HP and Dr. Rituparna from RCC Trivandrum. You are here? Yeah. Dr. Shabri and Dr. Nibin, please give the prizes to them. Congratulations, Dr. Darshan and Rituparna. And the other winners, the first was shared with GMC Kozhikode, Dr. Arathi K. Shivan and Dr. Rabia Bashir. Congratulations to both of them as well. Coming to the poster, again, the third goes to Dr. Don Andrews from GMC Trivandrum, third. He's not here. And the second is again shared with GMC Thrissur, that is Dr. Wafa Akbar Ali. And is she here? Wafa, yeah, please come on. There is a second. Congratulations, Dr. Wafa. Oh, the HOD is here. And it is shared with Dr. Elena and Anna Jacob from GMC Trivandrum. Congratulations, Dr. Elena. And the first prize again goes to Amrita Institute of Medical Science, Dr. Gautam Balaji. Congratulations, Dr. Gautam. Coming to the last session, like the oral paper presentation, the third prize goes to Dr. Arathi K. Shivan and Dr. Rabia Bashir. That is being shared, both from GMC Kozhikode. They are not here. And the second goes to Dr. Arya Suresh from Amala Institute of Medical Science. Congratulations, Dr. Arya. And the first goes to, it is being shared, first goes to Dr. A.M. Mohammad Fahim, RCC Trivandrum. Congratulations, Dr. Mohammed. And it is to be shared with GMC Kozhikode, Dr. Najia Suleiman. Okay? Congratulations to all winners. And hope you enjoy. Thank you. Thank you so much.
Thank you so much, sir. And congratulations to all the winners.
Dr. Arun Shankar sir was in charge of the souvenir committee. I invite Dr. Arun Shankar sir to the stage to speak to us.
The souvenir work was basically a collection of all the inputs and all the forms that you have filled, the directory and everything. It's not my work, it's just a collation of the information that you provided me. So the credit is not mine, it is yours. So I heard my name being said, I was just putting everything in a table in a nice format, that's all. The information, everything is yours. And I still want to remind everyone, those of you who haven't filled the information, there is still time. The final version will be released in a few days' time, so you can still give me information, whoever those who have not. Thank you. And I had all the help from my editorial board and the souvenir committee, including Jayakumar sir here. Francis sir was there, giving me very valuable inputs, and there were articles who were contributed by Madhu sir. He corrected the articles on the fly. I would, my many thanks to him as well. And thanks to all of you, and I need your support in continuing this document. This directory is not a one-day document or something. It has to be a regular one. It needs to be updated regularly, at least once in a year. So I'll be contacting you again. Since I'm there for 4 years, so I'll be contacting you again. Thank you.
Thank you so much, sir. Next, we have the vote of thanks by Dr. Shabrinath, Consultant Oncologist, General Hospital, Pala.
എത്രയും പ്രിയപ്പെട്ട എൻ്റെ അറോയി സഹോദരങ്ങളെ, മനോജ് സാറ് ക്ഷമിക്കണം, ഞാൻ ഇന്നലെ മൗസാറിനെ ഒത്തിരി വഴക്ക് പറഞ്ഞു മലയാളത്തിൽ പറഞ്ഞുകൊണ്ട്. ഇന്ന് ഞാൻ മലയാളത്തിലേ പറയത്തുള്ളൂ. വേറൊന്നുമല്ല, മലയാളത്തിൽ പറഞ്ഞാലേ ആ ഇമോഷൻസ് കൃത്യമായിട്ട് കൺവേ ചെയ്യാൻ പറ്റത്തുള്ളൂ. അതുകൊണ്ടാണ്. സത്യം പറഞ്ഞു കഴിഞ്ഞാൽ നന്ദി പറയാനായിട്ട് എന്നെ വിളിച്ചെങ്കിലും ഓൾറെഡി നിവിൻ ബോസ് എല്ലാവരോടും നന്ദി പറഞ്ഞു കഴിഞ്ഞു. ഞാൻ നിവിൻ ബോസും അടുത്ത സുഹൃത്തുക്കളാണ്. അദ്ദേഹം ഫെലിസിറ്റേഷൻ ആണെങ്കിൽ പോലും അദ്ദേഹം നന്ദി പ്രസംഗം അവിടെ നടത്തി. അപ്പം ഞാൻ തൽക്കാലം നന്ദി പ്രസംഗം ഒറ്റവാക്കി നിർത്തിയിട്ട് സംഘടനാപരമായിട്ടുള്ള 1-2 കാര്യങ്ങൾ പറഞ്ഞ് എൻ്റെ പ്രസംഗം അവസാനിപ്പിക്കാമെന്ന് കരുതുന്നു. ആദ്യമായിട്ട് തന്നെ എനിക്ക് പറയാനുള്ളൊരു പ്രധാനപ്പെട്ട കാര്യം എന്ന് വെച്ച് കഴിഞ്ഞാൽ, നമ്മൾ മൂന്നാർ വെച്ചിട്ടാണ് ഈ കോൺഫറൻസ് നടത്തിയത്. അതിൻ്റെ പ്രസക്തി എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ ഇതൊരു ഡെസ്റ്റിനേഷൻ കോൺഫറൻസാണ്. മൂന്നാറെന്ന് പറഞ്ഞാൽ തിരുവനന്തപുരത്ത് നിന്ന് ട്രാവൽ ചെയ്യുന്നവർക്കറിയാം, നിങ്ങൾക്കൊരു 7 മണിക്കൂർ കൂടുതൽ യാത്ര വരും. കോട്ടയത്തു നിന്ന് വന്ന എനിക്ക് പോലും ഒരു 4.5 മണിക്കൂർ എടുത്തു. എറണാകുളത്ത് നിന്ന് വരുന്നവർക്കെടുക്കും 4-4.5 മണിക്കൂർ. കോഴിക്കോട് കണ്ണൂരിൽ നിന്നൊക്കെ വന്നവർക്ക് അതിനേക്കാൾ കൂടുതൽ 8-9 മണിക്കൂറൊക്കെ എടുക്കും ഇവിടെ എത്താനായിട്ട്. അപ്പോൾ എന്തുകൊണ്ട് നിങ്ങളെല്ലാവരും ഇവിടെ വന്നു എന്നുള്ളതാണ് ആദ്യത്തെ ചോദ്യം. എന്തുകൊണ്ടാണിത്? റാദർ ദാൻ എ കോൺഫറൻസ്, നമ്മുടെ ആ ഒരു സംഘടനാ ബോധം നിങ്ങൾക്കെല്ലാവർക്കും ഉള്ളത് കൊണ്ട് മാത്രമാണ് ഈ കോൺഫറൻസ് ഇത്ര സക്സസ്ഫുള്ളായിട്ട് ഇവിടെ പൂർത്തീകരിക്കാൻ സാധിച്ചത്. സത്യം പറഞ്ഞു കഴിഞ്ഞാൽ നിങ്ങൾ ഓരോരുത്തരുടെയും, ഞാൻ സെക്രട്ടറി ആയ സമയത്ത് ഞാൻ ആദ്യമായിട്ട് എടുത്തൊരു തീരുമാനമാണ് സംഘടനാ ബോധം വളർത്തുക എന്നുള്ളത്. ഒരു കോൺഫറൻസിനേക്കാൾ ഉപരിയായിട്ട് അറോയി എന്നുള്ള സംഘടനയ്ക്ക് ഒരു സംഘടനാ ബോധം വേണം. നമ്മൾ അറോയി മെമ്പേഴ്സ് എന്ന് പറയുമ്പോഴത്തേക്കും നമുക്ക് ആ അറോയി മെമ്പർ എന്നുള്ള പ്രിവിലേജുകൾ വേണം. അറോയി മെമ്പറാണ് എന്ന് പറയുന്നൊരു അഭിമാനം വേണം. അത് വളർത്തിയെടുക്കുക നമ്മുടെ അംഗങ്ങളുടെ ഇടയിൽ നിന്നുള്ളതായിരുന്നു എൻ്റെ ആദ്യത്തെ തീരുമാനം. അതിൻ്റെ ഒരു വിജയമായിട്ട് തന്നെയാണ് ഞാൻ സത്യം പറഞ്ഞു കഴിഞ്ഞാൽ സ്വയം പരിശോധിക്കുമ്പോഴത്തേക്കും ഇന്ന് ഈ കോൺഫറൻസിൽ നിങ്ങൾ ഇത്രയും ആൾക്കാർ, വാഗമണ്ണിൽ നടത്തിയത് 138 ആൾക്കാർ വന്നിരുന്നെങ്കിൽ ഇന്ന് ഈ കോൺഫറൻസിൽ എനിക്ക് സ്പോട്ട് രജിസ്ട്രേഷൻ നമ്പർ എനിക്ക് കിട്ടിയിട്ടില്ല, 142 പേര് രജിസ്റ്റർ ചെയ്തിരുന്നു അതിനു മുമ്പ്. എനിക്ക് തോന്നുന്നു അതിനേക്കാൾ കൂടുതൽ ആൾക്കാരും കൂടെ വന്നിട്ടുണ്ടാകണം. പ്ലസ് ട്രേഡ് മെമ്പേഴ്സും മറ്റാൾക്കാരും കൂടെ ഒക്കെ നോക്കുമ്പോൾ 200-ന് മേലെ ആൾക്കാർ പങ്കെടുത്ത ഒരു സംഘടനാ സംവിധാനമാണ് ഇന്നിവിടെ നടന്നത്. നമ്മൾ അക്കാഡമിക്സിനോടൊപ്പം തന്നെ ചേർത്ത് കാണേണ്ട കാര്യങ്ങളാണ് സംഘടനയുടെ മറ്റ് ഭാഗം കൂടെ. അതായത് നമ്മുടെ GB നടന്നു, എൻ്റർടൈൻമെൻറ്റ് സെഷൻ നടന്നു. എന്തിനാണ് നമ്മൾ ഇത്രയും കാര്യങ്ങളൊക്കെ ചെയ്യുന്നതെന്ന് വെച്ച് കഴിഞ്ഞാൽ നമുക്ക് എല്ലാവരും തമ്മിൽ ഒരു ഇടപെടൽ നടക്കണം, നമ്മൾ അങ്ങോട്ടും ഇങ്ങോട്ടും മനസ്സിലാക്കണം, നമുക്ക് സൗഹൃദം സ്ഥാപിക്കണം. അത്തരം കാര്യങ്ങളും കൂടെ ഒരു കോൺഫറൻസിൻ്റെ ഭാഗമായിട്ട് നിന്ന് നോക്കുമ്പോൾ നമുക്ക് നടക്കണം. അതിനകത്ത് ഓരോരുത്തരും വഹിച്ച പങ്ക് അത് എടുത്തു പറയേണ്ടതാണ്. അതായത് നമ്മുടെ ഓരോ കമ്മിറ്റിയും, ഞാൻ ഒരു കമ്മിറ്റിയെ പോലും ഞാൻ പ്രത്യേകം പേരെടുത്ത് പറയുന്നില്ല, വേറെ ഒന്നും കൊണ്ടല്ല. അങ്ങനെ പറഞ്ഞു കഴിഞ്ഞാൽ എനിക്ക് എൻ്റെ സമയം അതിക്രമിച്ച് പോകുന്നതുകൊണ്ട് മാത്രമാണ് ഞാൻ പറയുന്നത്. എല്ലാ കമ്മിറ്റിയും കഴിഞ്ഞ വാഗമൺ അറോയിക്കോണിന് വെച്ചിട്ട് കമ്പയർ ചെയ്യുമ്പോഴത്തേക്കും ഈ മൂന്നാർ അറോയിക്കോണിൽ എല്ലാ കമ്മിറ്റിയും വളരെ നന്നായിട്ട് തന്നെ പ്രവർത്തിച്ചിട്ടുണ്ട്. നന്നായിട്ട്, പക്ഷേ ചില പിണക്കങ്ങളൊക്കെ അങ്ങോട്ടും ഇങ്ങോട്ടും ഉണ്ടായിട്ടുള്ള കാര്യം തുറന്നു പറയാം. പക്ഷേ അതൊക്കെ അതിജീവിച്ചുകൊണ്ട് വളരെ മികച്ച രീതിയിൽ എല്ലാവരും, എല്ലാ കമ്മിറ്റിയിലും ഓരോ കമ്മിറ്റി അംഗങ്ങളും വളരെ മികച്ച രീതിയിലുള്ള പ്രവർത്തനമാണ് ഇതിനകത്ത് സാധിച്ചത്. അതിനകത്ത് ഞാൻ എല്ലാവരോടും കൂടെ പറയുകയാണ്, കമ്മിറ്റി പ്രവർത്തിച്ചവരും എല്ലാത്തരോടും കൂടെ പറയുകയാണ്, അതായത് പിണക്കങ്ങളും ഒക്കെ എപ്പോഴും ഉണ്ടാകും. അത് വേണം, അതുണ്ടെങ്കിലേ നമ്മൾ തമ്മിലുള്ളൊരു അടുപ്പം വർദ്ധിക്കത്തുള്ളൂ. അതിനകത്ത് അങ്ങനത്തെ കാര്യങ്ങളില്ലെങ്കിൽ അതൊക്കെ ഒരു എന്താ പറയുക, ശരിയായ രീതിയിലല്ല എന്നാണ് മനസ്സിലാക്കുന്നത്. പിണക്കങ്ങൾ വരും, അഭിപ്രായ വ്യത്യാസം ഇല്ലാത്ത ആൾക്കാരില്ല. നമ്മൾ ഓരോ വ്യക്തികളും ഓരോ അഭിപ്രായമുള്ളവരാണ്. നമ്മൾ അങ്ങോട്ടും ഇങ്ങോട്ടും സംസാരിക്കുമ്പോഴത്തേക്കും നമ്മൾ അങ്ങോട്ടും ഇങ്ങോട്ടും പറയുമ്പോഴത്തേക്കും എൻ്റെ അഭിപ്രായം ആയിരിക്കത്തില്ല അടുത്ത ആൾക്ക്. അപ്പോൾ അതുകൊണ്ട് അഭിപ്രായ വ്യത്യാസങ്ങൾ എപ്പോഴും ഉണ്ടാകും. അതിനെ ആ സ്പിരിറ്റിൽ തന്നെ ഉൾക്കൊണ്ടുകൊണ്ട് ഇനിയും തുടർന്നെന്ന് ഞാൻ പറയാൻ കാര്യം, അടുത്ത കോൺഫറൻസ് നടത്താൻ പോകുന്നത് നമ്മുടെ പ്രേമോടമാണ്. നമ്മുടെ അറോയി സ്റ്റേറ്റ് ചാപ്റ്റർ നേരിട്ടല്ല കോൺഫറൻസ് നടത്താൻ പോകുന്നത്. ഇപ്പോൾ 2 വർഷം വാഗമണ്ണും മൂന്നാറും അറോയി സ്റ്റേറ്റ് ചാപ്റ്റർ നേരിട്ടാണ് നടത്തിയത്. അടുത്തത് അങ്ങനെയല്ല നടത്താൻ പോകുന്നത്. നടക്കാൻ പോകുന്നത് നമ്മൾ സെപ്പറേറ്റ് ഓർഗനൈസിംഗ് കമ്മിറ്റി ചെയർമാനും സെപ്പറേറ്റ് ഓർഗനൈസിംഗ് കമ്മിറ്റി സെക്രട്ടറി അടക്കമുള്ള ഒരു ഇത് വരും. പ്രസിഡൻറ്റും സെക്രട്ടറിയും എന്നുള്ള നിലവാരത്തിൽ ഞങ്ങൾ കൂടെ നിൽക്കും. പക്ഷേ അതിനർത്ഥം ഞങ്ങൾക്ക് സപ്പോർട്ടില്ല എന്നല്ല കേട്ടോ മാഡം, മനസ്സിൽ പേടിപ്പിക്കാനില്ല പറഞ്ഞാണ്. എല്ലാ സപ്പോർട്ടും ഞങ്ങളുടെ ഭാഗത്തുനിന്നുണ്ട്. എന്നാലും നിങ്ങളായിരിക്കും പരിപാടി നടത്തുന്നത്. അങ്ങനെ നടത്താൻ ഉള്ള ഒരു തീരുമാനമെടുത്തതിൻ്റെ ഉദ്ദേശശുദ്ധിയും മറ്റൊന്നുമല്ല, കൂടുതൽ ആൾക്കാർ നമ്മുടെ സംഘടനയിലേക്ക് വരണം, കൂടുതൽ പ്രവർത്തന താല്പര്യമുള്ളവർ സംഘടനയിലേക്ക് വരണം, എന്നാലേ സംഘടന വളരത്തുള്ളൂ. എനിക്കിനി ഇപ്പോൾ 2 വർഷം കൂടെ ഉള്ളൂ സെക്രട്ടറി ആയിട്ട്. അത് കഴിഞ്ഞ് കഴിഞ്ഞാൽ ഞാൻ ഒഴിയും. ജയകുമാർ സാർ ഇപ്പോൾ ഇന്ന് പ്രസിഡൻ്റായി, സാറിനും 2 വർഷമേ ഉള്ളൂ പ്രസിഡൻ്റായിട്ട്, സാറ് ഒഴിയും. അപ്പോൾ ആ ഒരു സാഹചര്യത്തിൽ പുതിയ നേതൃത്വം നമ്മുടെ കൂട്ടത്തിലേക്ക് വരണം. അതിനകത്ത് ഇപ്പം ഒരാളെ മാത്രം ഞാൻ പേരെടുത്ത് പറയാം, അത് പ്രത്യേകമായിട്ട് ഉള്ളതിനല്ല, എന്നെ ഞെട്ടിച്ച ഒരു വ്യക്തിത്വം അരുൺ ശങ്കർ സാറാണ്. ഞാൻ സത്യം പറയാം, ആസ് എ സെക്രട്ടറി ഈ സോനിയ ഇറങ്ങത്തില്ലെന്ന് ഉറപ്പിച്ചിരുന്ന വ്യക്തിയാണ് ഞാൻ. ഇനാഗ്രേഷനും പറഞ്ഞ കാര്യമാണ്. പക്ഷേ അദ്ദേഹം അത് ഇറക്കി. അത് അപ്രിഷ്യേറ്റ് ചെയ്തേ പറ്റത്തുള്ളൂ. അദ്ദേഹം അത് വളരെ ഡെഡിക്കേറ്റഡ് ആയിട്ട് ഈ സോനിയർ അദ്ദേഹം അത് ഇറക്കി. അതിനകത്ത് ഞാൻ പ്രത്യേകമായിട്ട് എടുത്തു പറയും. ഒരാളെയും കൂടെ പറയുന്നു, നമ്മുടെ സയൻറ്റിഫിക് കമ്മിറ്റി ചെയർമാൻ അരവിന്ദ് സാറ്. സത്യം പറയാം, സാറ് എൻ്റെ ഒരു അധ്യാപകൻ എന്ന് വെച്ചാൽ ഞാൻ സാറിൻ്റെ കൂടെയാണ് ഏറ്റവും കൂടുതൽ വർക്ക് ചെയ്തത്. തമാശയായിട്ടാണ്, കുറച്ച് ഓവറാണോ എന്നെനിക്ക് തോന്നി കോൺഫറൻസ് തുടങ്ങുന്നതിന് മുമ്പ്. പക്ഷേ സാറ് ഈ കോൺഫറൻസിൻ്റെ സയൻറ്റിഫിക് കമ്മിറ്റി ഇതുകൊണ്ട് സാർ അല്ല എന്ന് തെളിയിച്ചു തന്നു. അങ്ങനെയാണ് പ്രവർത്തിക്കേണ്ടത്. അല്ല സത്യം, ഇനി കോൺഫറൻസ് തുടങ്ങുന്നതിന് കുറച്ച് ഓവറാണ്. ഞാൻ തമാശ പറഞ്ഞതല്ല, കാരണം ആ രീതിയിലുള്ള കാര്യങ്ങൾ. അപ്പം ഞാൻ ഓർത്ത് ഇങ്ങനെയൊക്കെ നടക്കുമെന്നൊക്കെ ആലോചിച്ചു. പക്ഷേ സാറുണ്ടല്ലോ അത് തെളിയിച്ചു തന്നു, ഇങ്ങനെയാണ് കാര്യങ്ങളെന്നുള്ളത് തെളിയിച്ചു. സാറിന് പ്രത്യേക അപ്രിസിയേഷൻ സാറിനും ഈ അവസരത്തിൽ ഞാൻ നൽകുന്നു. ഞാൻ ഓരോരുത്തരും പേരെടുത്ത് പറയുന്നില്ല, പറയാനാണെങ്കിൽ ഒരുപാട് പേരുണ്ട്. അതിനകത്ത് എൻ്റെ കൂടെ നിന്ന വ്യക്തികളെന്ന് പറയാൻ പറ്റുന്ന നിംബോസ് ഓൾറെഡി പറഞ്ഞു, എബ്രഹാമും വിഷ്ണുവും. അവരില്ലായിരുന്നെങ്കിൽ സത്യം പറഞ്ഞാൽ ഈ കോൺഫറൻസ് ഇവിടെ നടക്കത്തില്ല. കാരണം അവരതുപോലെ നിന്ന് വർക്ക് ചെയ്ത വ്യക്തിത്വങ്ങളാണ്. എന്ന് വെച്ച് കഴിഞ്ഞാൽ നമ്മൾ ഒരു സാധനം ചെയ്യണമെങ്കിൽ അതിനകത്ത് ഫിസിക്കൽ വർക്കെന്ന് പറഞ്ഞെടുക്കുക, നമുക്കൊക്കെ നിർദ്ദേശം കൊടുക്കാൻ പറ്റും. ഫിസിക്കലി കാര്യങ്ങൾ നടപ്പിലാക്കണമെങ്കിൽ ചില വ്യക്തിത്വങ്ങൾ വേണം. അങ്ങനെ നിന്ന് പ്രവർത്തിച്ച 2 ആൾക്കാരാണ് അവർ. അപ്പോൾ അവരെയും ഞാൻ പ്രത്യേകമായിട്ട് എടുത്ത് പറഞ്ഞു. ഞാൻ ഓരോ കമ്മിറ്റികളിലും കടക്കുന്നില്ല. പറയാനാണെങ്കിൽ നമ്മുടെ ഡോക്ടർ അനൂപ്, അതുപോലെ തന്നെ നമ്മുടെ ഡോക്ടർ ദിലീപ്, ഷിൻഡോ, സോമു, ജൂഡിത്ത്, ഞാൻ വിട്ടുപോയെങ്കിൽ ക്ഷമിക്കണം കേട്ടോ. കാരണം എല്ലാ കമ്മിറ്റിയുടെയും എനിക്കിവിടെ പറയാൻ പറ്റത്തില്ലാത്തതാണ് പറഞ്ഞത്. എല്ലാവരും, എല്ലാ കമ്മിറ്റികളും അവരവരുടെ പ്രവർത്തനങ്ങൾ വളരെ മനോഹരമായിട്ടും വിജയിച്ച രീതിയിൽ തന്നെ നടത്തിയത്. എനിക്കൊരു കമ്മിറ്റിയെക്കുറിച്ചും ഞാൻ വിമർശനം ഉണ്ടെങ്കിൽ തുറന്നു പറയുന്ന ആളാണ് ഞാൻ. വിമർശനം ഉണ്ടെങ്കിൽ ഞാൻ അത് മുഖത്തടിച്ച് പറയും. അപ്പം അതുകൊണ്ട് എൻ്റെ നോട്ടത്തിൽ അങ്ങനെ പ്രത്യേകിച്ച് ഒരു കമ്മിറ്റിയും ഒരു മോശമായി പ്രവർത്തിച്ചു എന്ന് എനിക്ക് തോന്നുന്നില്ല. അല്ല, ജയകുമാർ സാറിനും അങ്ങനെ തന്നെയാണ് തോന്നുന്നതാണ് എൻ്റെ വിശ്വാസം. അപ്പോൾ എല്ലാ കമ്മിറ്റിയും വളരെ മനോഹരമായിട്ട് തന്നെ പ്രവർത്തിച്ചു. അപ്പം നമുക്ക് നല്ല ഒരു കോൺഫറൻസ് ഇന്നിവിടെ പൂർത്തീകരിക്കാനായിട്ട് സാധിച്ചു. ഇനി അടുത്തത് നമ്മൾ തൃശ്ശൂരിലാണ്. അതിൻ്റെ അപ്ഡേറ്റ്സ് നമുക്ക് ഉടനെ തന്നെ ലഭിക്കുമെന്ന് ഞാൻ വിശ്വസിക്കുന്നു. ഇതിനേക്കാളും മികച്ച രീതിയിൽ കൂടുതൽ നല്ല പാർട്ടിസിപ്പേഷനോട് കൂടിയിട്ട് ആ കോൺഫറൻസ് നടക്കട്ടെ. നമുക്കതിനും എല്ലാവരും വരണം. കാരണം അത് ഞാൻ എടുത്തു പറയുന്നൊരു കാര്യമുണ്ട്. വാഗമൺ കഴിഞ്ഞു, മൂന്നാർ കഴിഞ്ഞു, ഇനിയിപ്പോൾ തൃശ്ശൂർ സിറ്റി എന്നെ കാണാനാന്നുള്ളൊരു കാഴ്ചപ്പാട് എടുക്കരുത്. നമുക്ക് ഞാൻ പറഞ്ഞ ഡെസ്റ്റിനേഷൻ കോൺഫറൻസ് ഉണ്ടെന്ന് നടത്തിയോളാം. ഞാൻ അങ്ങനെയായിട്ട് പറഞ്ഞ് അങ്ങനെ പ്രശ്നമുണ്ട് മാഡം. എനിക്ക് തോന്നുന്നു ആതിരപ്പള്ളി വാട്ടർഫാൾസിനടുത്ത് നടത്താൻ സാധ്യതയുണ്ട് മാഡം. അത് അല്ല, അങ്ങനെ ഉണ്ടെന്നുണ്ടെങ്കിൽ എന്നാലും ഞാൻ പറഞ്ഞാണ്, നമുക്ക് അടുത്ത കോൺഫറൻസ് ഇതിനേക്കാൾ 138 വാഗമണ്ണ്, ഇത് 142 ക്രോസ് ചെയ്ത്. എൻ്റെ ഒരു കണക്ക് ആണെങ്കിൽ 150 അല്ലേ ഗായത്രി? 150 വന്നിട്ടുണ്ടോ? അപ്പം 150 മേലെ രജിസ്ട്രേഷൻസ് വന്നിട്ടുണ്ട്. അപ്പോൾ അടുത്തതിന് നമുക്ക് അതിനും മികച്ച രീതിയിൽ പോകണം. എല്ലാവരും പങ്കെടുക്കണം. ഇതിനേക്കാൾ മികച്ച രീതിയിൽ അക്കാഡമിക് സെഷനും അറ്റ് ദ സെയിം ടൈം നമ്മുടെ സംഘടനാ ബോധവും എല്ലാവർക്കും വളർത്തേണ്ട ആവശ്യങ്ങളുണ്ട്. പുതിയ നേതൃത്വങ്ങൾ വരേണ്ട ആവശ്യമുണ്ട്. പുതിയ പ്രസിഡന്റ് വരണം, പുതിയ സെക്രട്ടറി വരണം, പുതിയ വൈസ് പ്രസിഡന്റ് വരണം, പുതിയ എഡിറ്റർ വരണം. അങ്ങനെ എല്ലാ കാര്യങ്ങളിലും ഒരു സംഘടന എന്നുള്ള നിലവാരത്തിൽ വളരേണ്ട ആവശ്യം നമുക്കുണ്ട്. അപ്പം അതിനു വേണ്ടിയിട്ട് എല്ലാവരും കൂട്ടായി പ്രവർത്തിക്കുക. നിപിൻ ബോസ് നേരത്തെ എല്ലാവർക്കും നന്ദി പറഞ്ഞുകൊണ്ട് ഞാൻ ഓരോരുത്തർക്കും നന്ദി പറയുന്നില്ല. നന്ദി.
Thank you so much, sir. By this, we have come to the end of the valedictory function. I once again thank all the delegates and all the participants present here. Hope you all had a wonderful academic feast and you all enjoyed participating in the various competitions. And also, above all, you had a pleasant stay here at Munnar. Okay. Thank you so much. Now let's disperse for lunch, which will be served at the restaurant in the -1 level.